Yeah, welcome to the first session of SAC Global Health. Firstly, thank you for bearing with us. So our first session is titled Introduction to Global Health. I'm Adriana Miranda. I'm one of the co-founders of the Students Against COVID and also the co-organizing lead of the Global Health Program, who will be the MC for today's session. It is truly an honor to welcome every one of you here. You are students and professionals from 90 countries across the globe. And I believe that you are all very excited to learn more about global health with us. The COVID-19 pandemic has shed light that the world needs coherence, context, and a bigger picture about the global health challenges encountered daily and its foreseeable prospects. Therefore, we hope that this event will be able to firstly introduce you to global health. If you have not filled the pretest form that we sent through your email, please kindly fill it since we really need it for our program evaluation. It's bit.ly GHP pretest. We also would like to take this moment to thank our 15 partners and collaborators for making this event possible. Firstly, it's the International Association of Dental Students, African Novice Nurses and Student Initiative, Medical University of Sofia Debating Society, Global Health Youth Foundation, the Standing Committee of One Health and International Veterinary Students Association, International Pharmaceutical Students Association, European Institute of Innovation and Technology Health Alumni, International Federation of Physician Assistant or Physician Associate and Clinical Officer or Clinical Associate or Comparable Students Association or IFPACS, Squad Medicine and Research, Swedish Network of International Health, Digital Health and Patient Safety Platform, the Journal of Heart, Vessels and Transplantations, Turkish Medical Student Journal, Make Medical Easy, and Global Health International Congress. Next up, I would like to invite my co-lead, Manahil Khan, to speak some words about the Global Health Program. Manahil, the floor is yours.
Hello, everyone. Okay, so I am Manahil. I'm along with Adriana, co-leading this Global Health Program. First of all, it is with great honor and joy that I extend my warm welcome and a really pleasant time to all of you to our Global Health Program. We are really excited to bring this opportunity of holding this series of innovative and virtual conferences to encourage activists, clinicians, leaders, decision makers, futurists, and all those who care about the world and its future. Humanity needs global, bold, and long range goals to excite the imagination and inspire international collaboration, which we believe we can promote through this program. And the organization of these activities is a perfect allusion of our efforts to enhance the initiatives which are taken to achieve the objectives of this program. As the name implies, global health is about the global health of the people. And if you don't live in a community where the diseases are prevalent, they might seem like far away issues, but global health affects everyone. That's why everyone everywhere should play a role to end these diseases. And there are many ways to improve the global health, including reducing inequities, combating preventable diseases, and making healthcare accessible and affordable, which we believe and we will cover throughout this session. The program will provide you with an opportunity of the most important health challenges that the world is facing currently. You will gain an insight into how the challenges we face have changed over time, just like how this most crucial one right now, the COVID-19, has impacted our lives. We will discuss the likely determinants of such changes and examine future projections. Successful international strategies and programs promoting human health will be highlighted, and global health governance structures will be mapped, and the role of the key factors explored. Experts, we aim to devise actions suggested to address the global health challenges and to develop more appropriate strategies to our unique situations. We believe in integrated understanding of our world's problem and potential opportunities to identify and implement strategies on a scale that is necessary to address the global issues. As we announced about the sessions being organized by the widely renowned International Association of Dental Students, it is with great pleasure to tell you all the dates to these sessions, which will be 22nd of August 2021. The topic of our first talk will be global prevalence and drivers of dental students' COVID-19 vaccine hesitancy by the Vice President of Research from International Association of Students. And the second talk will cover about the youth involvement in the global oral health. With that, I would also like to announce that we will be conducting a networking session after these talks to allow positive networking among the global health enthusiasts. Through our networking session, we hope to foster youth-led collaboration and knowledge sharing, which is crucial to navigate through these uncertain times. Reducing new frontiers requires fresh vision and novel strategies. Producing the conference online fits perfectly with these aims to reach a wider audience, just like we got like 1,000+ people engaged from 80 different countries in our global health program. So we hope we'll be able to nourish our skills through this series of online webinars, interactive sessions, networking sessions, and debating on global health issues. I'm really looking forward to a fun and insightful workshop. Thank you.
Thank you, Manahil. Next up, we'll go to the explanation a bit about SAC. It won't take long. Firstly, we would like to welcome Dr. Opara to our event. Dr. Opara will be our first speaker. But before we go on to Dr. Opara's talk, we will continue to the introduction about SAC first. So I will be presenting about SAC on behalf of the other volunteers as one of its co-founders. So, firstly, before I know that many of us here are already within SAC, and I hope that for you who are not part of the SAC movement, that you will consider to be a part of us after you see the screen, after you see this presentation, and after you learn more about global health with us through this program. So yeah, a brief about SAC is that SAC is a youth-led global grassroots movement. It has representatives from 110 countries, and we're supported by the Pollination Grant and also DICE Foundation. So recently we won the award given by the CUGH and Pulitzer. We won the High Impact Program Award, and CUGH is one of the largest consortium or conference in global health in the world. So currently, as I've said before, we have members from 110 countries, and we represent a spectrum of careers, ages, and educational backgrounds. So we don't only accept healthcare students to SAC, we also accept people from other fields such as IT, fisheries, design, and even high school students, and also elementary students in special cases when the parents give their permission for them to join us. And it began as a Twitter US co-founder, and 1 year later, the suite has grown into a very big movement with over 1,300 volunteers. And these are our mission. So we aim to firstly spread credible information by making flyers and campaigns. And we also aim to empower students and allies' voices, as well as fostering collaboration and innovation between them. And lastly, to encourage social accountability by raising awareness about inequities and encouraging transparencies about the COVID-19 pandemic and also its responses. So our motto is, once you decide to make a change, you rock the boat, because we believe that change firstly start with a change of your heart. If you start And if you decide that you can change the world, then the first step, which is the hardest one, is already done. And this is more about us, so it will be just a bit about our program. So we do online campaigns. Currently, over the past year, we've made 1,000 educational materials with 6 million impressions all over our social media. And this campaign is translated into 39 languages. So to reach people from all over the world globally, including immigrants, refugees, etc. And these are our other campaigns. So our healthcare workers also use our flyers to help explain about COVID-19 to their patients. We also make TikToks, videos, podcasts. We also held competitions. This one is for kids. So held other health campaigns since we believe that health issues that were already there during the world before the COVID-19 pandemic is also exacerbated by the pandemic. So we also raised awareness about other health issues such as the women's health issues, mental health, and child's health. And we also hold on-ground campaigns. Currently, we do it in 4 countries: India, US, Pakistan, and the UK. And in India alone, we have disseminated over 3,000 masks, and it's still ongoing. We also have the opportunity to associations alongside other professional organizations. We also do skill development programs for our volunteers, such as trainings, workshops, and also competitions. We also promote research and publications and for our volunteers. So we have a special team dedicated to improving research skills within our volunteers. These are about students against COVID, but actually we have some other projects going on as well, including about mental health, screen time, etc. And we've also been covered in media, in TVs, in UNICEF blog, and other info with SAC. There are 3 major benefits that you will get. The first one is that you will get first-hand experience of working together with students and young professionals from all over the world. And this is very beneficial because you will get to experience firsthand the different cultures in the world, and it will really widen your horizon. And you will also learn to manage work more effectively because each volunteer will have different time zones. And you will also get a volunteer certificate. And there are also additional benefits from partners. I'm sorry if this one is wrong. It should be 2-week free trial alumni, as well as other benefits offered by partners. These are our teams. I believe you can know about this better if you are interested, because we have it in our form. So if you want to get involved, you can just press join us in our website. It's sacov19.com. And then you can directly press this button and it will directly send you to our intake form. So yeah, that's all about SAC. I hope that it will interest you guys about it. And so next up is the session with Dr. Opara. The moderator for the session will be Monica. Monica is a medical student from India.
Thank you, Ariana. Greetings, everyone. I'm Monica, who will be your moderator for this talk. Our first talk will be about the Global Health Education Reimagined, a case study of Wayne State University Global and Urban Health Equity Program. Blue. Before we start, I would like to introduce our honorable speaker, Dr. Ijeoma Opara. Dr. Opara MD is an internationally recognized double board certified physician, public health professional, speaker, and consultant. She helps communities, organizations, and systems solve the problem of creating equitable, just, anti-racist, and decolonized environment in order to achieve their mission and meet their bottom line. She sent us Black and indigenous African brilliant solutions and library her asset-based work as an educator, activist, scientist, and clinician. She has created and led various programs catered towards graduate education in health equity. She has received significant recognition by her peers and nationality for her tireless effort towards bringing the gap and raising awareness on racial disparities exacerbated by the COVID-19 pandemic. I would I would take a moment and like to be very grateful that Dr. Opara have came to this presentation and have agreed to present this meeting for everyone here on this very short notice. Thank you so much, ma'am. Now, I would like to welcome Dr. Opara here.
Good morning. Can you hear me okay?
Yes, we could hear you. Greetings. Thank you for being here.
Greetings.
We thank you so much for being here on such short notice. We couldn't have done this without you.
Thank you. It's my pleasure. You know, you may not believe this, but I was a student at one point. And so, so I know how it is, you know, and I also plan events and do different similar things to what you're doing. And things happen. Life happens, you know, people drop out at last minute. We're living in unperilous times. It's just, you know, we have to be flexible. So other people, when I was at your stage, were very gracious and kind and generous with their time and expertise with me. And so it is my job to pass it on and pay it forward, like we say. Okay, so thank you for having me this morning. And I already see Imran is chatting. I'm from Bangladesh. So I want to first of all say good morning to everyone. Put in the chat, introduce yourself and where are you calling in from? You know, where are you coming in live from? I'm coming to you live from the city of Detroit, the state of Michigan, United States of America in North America. And I'm also representing Nigeria, West Africa, because that's my country of origin and I represent wherever I am, okay? So go ahead and put, you know, in the chat where you're calling in live from. I want to thank the organizers of this wonderful program, Students Against COVID, and so many other partners and sponsors. I especially want to thank our special guests, which are you all that are calling in, all the students and attendees. You are the special guests of honor. I want to thank you. And I love the previous leader, because you all are leaders, what you all said. You said something about if you're going to join the organization and change the world, you have to change your heart first. Oh, that made me so happy to hear, because I say that all the time. You can't change nothing externally until you are transformed internally. And so the work of internal transformation needs to be done before the fantasies of changing anything externally. And so I am so proud of you all that you already have mastered that reality. So with no further ado, because I know we're on a time crunch with the program, let me go ahead and share my screen and so that we can get into what we are gonna talk about today. I'm gonna ask the host to allow me to share, please. Make me a co-host or something.
Okay, we believe we've made you co-host.
Okay. Okay, great. And just so you know, sometimes I don't have the best, what do you call it, Wi-Fi, because my office is in the basement and sometimes I don't get the best, you know, reception. So if you can hear me at any time, please don't hesitate to let me know. You can either send me a chat or a buzz or just interrupt me. Or you can text me. Marina has my number. So you can text me and let me know. So my wonderful people, my good people, we are here to talk about today. I am, you know, like was said earlier, Monica talked about, I was invited into this just yesterday because there was a change in plans. So I did the best I could to come up with this conversation, this discussion, and I hope that it meets the expectations, and that at the end of the day that you all get incredible value from it, and that you take away something tangible that will make you a more powerful global health advocate, professional, leader, in whatever area of field that you are interested in, serving within the field of what we call global health, and I believe is going to actually change its name. I believe there is a movement to reimagine global health in a way that includes even the reimagination of what we call it. And that can be part of our conversation. So the topic today is global health education reimagined. And I'm hoping to use the program that we started at Wayne State as a case study. But before we get started, I always like to start with an acknowledgement of the indigenous land and my ancestors. And so with gratitude, I acknowledge that the land that I live, work, learn, and commune on is the original homelands of the Anishinaabe, Ojibwe, Odawa, Botawa, Tomi. And I acknowledge the painful history of genocide and forced removal from this territory of Detroit, or Wawiatanong in Anishinaabe language, and commit to learning how to be better stewards of this land. I also acknowledge with gratitude my ancestors who lived, loved, fought, and died for justice and liberation, that I may exist as a free, proud, Black African woman. So I want to invite you all, put in the chat your own land and or ancestral acknowledgement. If you already living and working and learning on land that belongs to your family, originally belonged to your family or to your ancestral line, acknowledge your ancestors. If not, acknowledge the original owners of that land. It is very important. So I want you to invite you to put that in the chat. I want to appreciate some key people in my life, which will be my three little queens. These are my three daughters, Ugochinyere, Onre Bubechi, and Chimamanda. And my partners in global health, Dr. Jamie Snell and Ms. Elizabeth Vasquez, and I'll reference them later. So what I'm hoping today to do is to highlight some of the changes in the global health education landscape and invite for both of us, you all, myself, to together reimagine what global health can be, and then to highlight and exemplify the case study of my program. A lot of time will be spent more in the first two goals, so to speak, and just a little bit with the case study, because you can truly find out more about us online. So, but I'm hoping that we will have more of an engaging conversation. It is very important for when I speak to talk about my positionality. And if you all don't know what that is, positionality is basically just talking about where are you coming from? Where are you standing in life? What is your position in life? Your history, the stories that make you who you are, that inform and frame the way you move in the world and what you do in the world, and your why for doing what you do. What is your story? What is your narrative? What are the forces and actors in your life that inform your actions and your activities, inform the ways that you engage in the world, right? So I am an Ada. And so an Ada is the firstborn daughter to an Igbo Nigerian family. And an Ada is given incredible responsibility. And Ada are natural leaders because you're trained from birth to lead and to be concerned about issues of justice and equality and equity, and to be concerned about building community and seeing the interconnectivity and interdependence in different things. You are tasked with learning the stories of your family and your community, keeping those stories and then disseminating those stories to your siblings and to the other members of the community. It's a position of incredible responsibility, leadership, and also celebration as well. It's a special position, and it has informed many of the reasons why I engage in the work that I do. Both my parents survived the Biafra Nigerian Civil War and were very active, particularly my father, even in that war as a young person. So, and that issue is still an issue of consternation in my country, Nigeria, today. There is still opportunity for truth and reconciliation to occur in that nation as it regards to many of the issues and the vestiges of that conflict, of that war. So this idea about justice and fighting for what is right, this idea of building communities, seeing the interconnectivities in things, this idea of ensuring that knowing the history, my history and the histories of people that look like me all over the world, so in the continent of Africa and throughout the diaspora, and ensuring, understanding that, and then having that inform the present and bringing about, justice in order to correct the hurt and the harm and the damage and the vestiges of those painful histories, especially as it relates to white supremacy and colonialism, and anti-Black racism and anti-Blackness, both internalized and externalized, came from a very early age. Okay, and has informed many of my activities to date. And so some of the activities I listed here in terms of my role in global health, so I hold leadership positions in the Consortium of Universities for Global Health, CUGH, as I think was mentioned earlier, the academic, American College for Academic International Medicine, the Accreditation Council for International Medical Programs, Women Leaders in Global Health, okay? I also am the co-founder of our Global Health Alliance and Global Urban Health Equity Program, which I'll be talking about today, and also the co-founding director for both, including health equity justice in medicine and our social that deals and focuses on training of medical students and health professional students, residents, faculty in social and structural determinants of health. My research focuses around asset-based frameworks as it relates to engaging with African and African diasporian communities. I'm particularly engaged in a bi-directional research project between us in Detroit and Ruli, Rwanda, called the Hope Project with Robert Wood Johnson Foundation. I'm on the editorial board for PLOS, or Public Library of Science, PLOS Global Public Health Journal, which is a new journal. And I encourage you all to submit, okay, because we are taking submissions now. And I'm the co-section editor for Racism and Health. And in my clinical practice, as an internal medicine and pediatric double board certified physician, I take care of people made vulnerable. So many of our patient panels are poor, lower socioeconomic status, people of immigrant backgrounds, and African Americans who are also in where in our area are poor and have other negative social determinants of health. But my focus is to leverage the positive social determinants of health, those assets that they have, in order to leverage that to positively impact their health outcomes. Because again, as someone who practices what I call liberation medicine, I do not operate from a deficit standpoint. I operate from a asset-based standpoint and a standpoint of strength. And that's part of what it is to decolonize medicine. And we'll talk about that as we go forward. So what I want to invite you all to do, and I'm going to do the best, I'm not always the best with this, okay, but I'm going to do my best to kind of juggle back and forth. And that is, I want you all to react, okay? Throughout this conversation, I want you all to be reacting in the chat because there are 267 and counting people on the call. Usually in my conversations, in my discussions, they tend to be very interactive. I have people on what's the word, on mute and talk and things like that. But I think that this needs to be more of a controlled environment, and the organizers, I'm sure, agree. And it sounds like what I can tell is that's what they're trying to do. So if I have you all on mute, it might get chaotic quickly. And I know you all are calling from different parts of the world. So what I want you to do is to go gangbusters on the chat. That means just use the chat freely. And I'm going to do the best I can to be checking in on the chat and going from there. So, and now that I said that, I'm actually going to look at the chat really quickly and see Ngige Azuka. I'm going to be calling folk out. Hi from Nigeria. Hi. Mohammed, hi from Northern Cyprus. Shout out to Ruksha from Pakistan. Shout out to Diva from Indonesia. Shout out to Fortune, who can't hear anything, and I hope somebody can help her out with that. Shout out to Samantha from Indonesia. Shout out to Hafsa from Kenya. Ken, who is already proud to be a Nigerian. All right, honey. Look, we stay proud. Yasmin is Iraqi and living there. And shout out to you, my dear. Aliyah from Morocco. Arshia, I see you. Hello. Hello, Michelle from Zimbabwe, and so on and so forth. So greetings to everybody. Nabila from India. From Egypt, I see Nurhan. Faiza from India. Shout out, shout out, shout out. Albania, Zorka. Oh, sorry, Zorka is from Hungary and Blesta is from Albania. Yeah, I see you, Mohammed from Sudan. So shout out to all y'all, all 268 of y'all, okay? So continue to use the chat because I'll be asking questions and I'm inviting you to answer in the chat, and I'll do my best and, to ensure that I'm checking in. All right, Eniola, I see you, girl. I see y'all. All right, beautiful. I love it. I already love the engagement. So I want to invite you to react, okay? And by react, I mean reflect, engage, and act. All right. So I'm hoping that as we have this conversation, we will be reflecting together. You'll be engaging in the chat and with each other. Okay. And that at the end of it all, that you will be action oriented. So I want to start with this. I don't know how many of y'all put in the chat if you all have seen this article. I believe this was published yesterday. If yesterday was the 14th, I believe, then it was. I want to invite y'all to think about this. This was published by Dr. Tedros. Okay, you all should know Dr. Tedros Ghebreyesus, who is the WHO Director General, right? And this article that he wrote for Time Magazine, why there should be a moratorium on COVID-19 booster shots until low-income countries get vaccinated. I want you to think about that. And he wrote this wonderful, it's actually not it's a pretty good article. And I want to invite you, if you haven't seen this, please check it out. But if you have, I want you to put in the chat what you thought about some of the issues that came up in this article and reflecting on, what's going on right now in terms of COVID-19, the pandemic, but also particularly the vaccine, in terms of the distribution of the vaccine, both in your country, but also worldwide. What are your thoughts about this? And we're going to revisit this in a second. But I want you to just kind of think about it and put your reactions oh, great, Michelle, you saw it. Princess has seen it as well. So Michelle, Princess, put in the chat, like, what were your thoughts? What issues came up for you? And you don't have to write a glorious, a soliloquy, just words, just little words here to you. And thank you, Fadele. You like my smile. I like your smile too, my dear. Thank you. So yeah, what people are getting ill after vaccination. Okay, I'm thinking that's what's happening in vaccination. Right. I mean, in your country, people are getting ill. Okay, all right, I see that. Princess, it says vaccine inequity, shit it on the head. Okay. When we're talking about this issue right here, it really ultimately is this sense that, wait a minute, most of the vaccines are going to countries in what is termed high income and low income. Personally, I don't use those terms because I don't define the region, and many of us don't define ourselves and the region where we come from by simply economic indices, and also economic indices that were not produced or developed by us, by other people, based on a value system that doesn't belong to us. So I don't necessarily ascribe to what is low or high income. However, I would say that whatever terms and names that is applied to these regions, it's still the same pattern, right? Whether they're called high income, developed, first world, whatever is the latest terminology, it's still the same region of the world fitting those same patterns, right? And then it's the same region of the world fitting the pattern of less, and the same region of the world fitting the pattern of more. It's the same pattern, no matter the labeling, right? And as long as we're not the ones doing the labeling, it's always going to fit that pattern. It's always going to reinforce hegemony. It's always going to reinforce power dynamics. It's always going to reinforce hierarchy, right? The same countries, mostly in Europe and North America, North America, so mostly US, Canada, and Europe, right? And then everybody else below. It's always going to reinforce that hegemony. And then it's going to be perpetuated and exemplified in whatever issue hits us as a world and as a country, right? So those same dynamics of power and hierarchy are simply reinforced by whatever assault or insult, hits any given entity, any given society, any given community, right? And regardless of what you label it, the issue isn't the name, is what the name implies and reinforces. And then what it implies and reinforces shows up in real life, in very real things like vaccine inequity, like Princess just said. So this issue about the certain part of the world hoarding most of the vaccines while the rest of the world is still struggling to get shot number one. And then that same part of the world, which again, there is some complexity, right? Because we understand vaccine hesitancy, vaccine resistance, and disinformation are also dynamics impacting on who is getting the vaccine, even in these so-called high-income countries, okay? However, or high debt countries, because again, a lot of these countries that are high income are also high debt. So again, who is defining what is wealth, what is resource rich? Again, it's an issue of power, because the same countries that are high income are the ones most in debt. So that's the point that I was trying to make about power differentials. But anyway, going back to the point, even in those countries, like the country I'm in, which is the US, right? Not everybody's getting the vaccine. Some of them, because there is inequitable vaccine distribution, and so there's just poor access from poor public health, like planning and implementation. But shout out to all the people that are doing great work to correct that, okay? So always shouting out. However, when compared to, again, the rest of the world, in general, it's not the same. Folks are here getting 2 shots and not about to get a third, while there are folks in other parts of the world that have not even gotten number 1, even though they're waiting, like these folks in this picture. And what becomes important is why? Why, right? Because oftentimes in global health, what happens is that we are just making these observations and then we note them and then we try to fix them. But those things are really just symptoms. They're the fruit of a poison tree. And if you don't address the poison tree, if you don't address the root, honey, that tree is just going to keep bearing bad fruit on and on again while you're out here just trying to cut off the fruit. You're dealing with the symptoms. You haven't addressed the pathology. So that is, I want you to just kind of sit with that as we have the rest of the conversation, because I want you to massage those thoughts. And for those that did read it, like Princess, okay, what was missing in that piece, in that article? What should have been said? What could have been said, right? So I want you to sit with that and reflect. Remember, we are reacting throughout. We are reflecting, we're engaging, and we are building action throughout this conversation. And this is the first of that. So I just want to visit the thread for a little. I want to encourage you all to interact with each other. You know, I might not be able to get to all the threads because I want to be able to get through the talk before, before time. So I want to also encourage y'all to interact with each other, because I might not answer everything right in real time, but I do want to visit it real quick. Yasmin says, in my country, they are forcing it. They said, if you're not vaccinated, you can't travel. That's true. Sarah says, I feel ashamed to say I took my shot mainly for the traveling reasons. I consoled myself that vaccine is not only doing good to me, but cannot blame anyone. The world is at stake. You got to cherish whatever is available around you. You cannot take chances at times like this. Well, Sarah, I just want to say I love you for being so vulnerable. We can't afford shame. Let me tell you something. I got my vaccine months after. I got my I forget, was it January or February? Months after it was available. Because I wanted to learn more. I didn't know enough, even as a doctor and a scientist. I had to do my due diligence. And I also was, again, because I do a lot of work in anti-racism and liberation, anti-colonialism. So I had to make sure that funny business wasn't going on either. So please, Sarah, don't be ashamed. You got your shot. I don't care what the reason was for it. You got it. And now you're protected and you're protecting other people. You're great. However, we get to the right answer, some of us, our journeys are all different. Some of us come straight through, some of us go like this, because we all have different life experiences. The point is that we get there. So do not feel any shame. And thank you for getting vaccinated. So when you hear global health, what do you think? Now put that in the chat. What is global health? What is it? Put it in the chat, what it is. So at a conference in 2000, in the 2000s, way back when, in the 2000s, there was a conference where Copeland and a bunch of other folk, and of course it was a part of the CUGH, Consortium of Universities of Global Health, came together, and they defined global health as a field of study, research, and practice that places a priority of achieving equity in health for all people, involving multiple disciplines within and beyond the health sciences, and is a synthesis of population-based prevention and individual-level clinical care, promoting interdisciplinary collaboration. Like many of you all, I was made to understand that we have medical students and nursing students and pharmacy and all kinds of folks. I love that. So promoting interdisciplinary collaboration and emphasizing transnational health issues and determinants of health, okay? So that was that definition. However, there was another doctor, an African doctor. I think it was a Kenyan doctor, but I want to say African doctor because I'm not 100% sure, but I think it was a Kenyan doctor. Oh, it was a Kenyan doctor. And at that same meeting, he offered an alternative definition. Said, well, is it a concept fabricated by quote unquote developed countries? Because again, what really is development, really? What are the metrics of development and who gets to set those standards, right? But so by developed countries to explain what is regular practice in developing countries. So I have a wonderful colleague that I'm working with, and she wrote a great paper, which I'm happy to share later. Excuse me, Emily Besson. And she wrote a great paper in the Lancet. And while we're working together on another paper, and she said, I'm glad that you're working, that your journal, the journal you're part of, you're on the editorial board, is called Global Public Health, not Global Health. Because as we know, global health and its roots, right? It's rooted in tropical medicine, which was created essentially to care for colonizers and colonists that came back to London, to Europe, to England, from doing colonial work in tropical regions, and got sick and came back to get treated. And so the field of study built around providing care for them, it was tropical medicine, and evolved to what we call global health. And so it's a sore spot and a thorny subject for a lot of folk. And that's why this Kenyan doctor said, wait a minute, it's just describing what we all do, everywhere, every day in our countries. And my friend, Emily, saying like, again, it's not a standard one thing, so to say global public health makes more sense to me because you're describing what is public health and what is health and healthcare in different contexts all over the world. So that's why I said in the beginning that this definition is going to morph. And you all young people are part of that conversation. You, especially those of you that do not live in Europe and or North America. Okay, when I say North, you know, there are other countries in North America, right? You all know this more than I. So I'm referring to mostly US and Canada. But the rest of the folks, that's what I'm referring to. Of course, there are other countries in North America, the North American continent. So I am mostly referring to US and Canada. And so those of us that are from not those areas need to be part of redefining, reimagining and redefining what this field is what it's going to look like, and what it's going to be called. I have another friend, Dr. Yao, who's Ghanaian, a PhD scientist, brilliant guy. And he basically defines global health. Oh, is health practiced in 2/3 of the world? In most of the world, majority of the world is what folks in, again, North America and Europe call global health. So it begs the idea of you know, who gets to define what within this field. And so the lines are blurred because you know, global health oftentimes it tends to refer, like when we use it in the ways that we use it, especially in the US and Europe, right? Global health, oh, health that happens over there, wherever over there is, right? Over in Africa, right? Because Africa is usually called as a country, right? When it's not. I hope we know that. Right? Over that's happening in Asia, over there happening in India, over there happening elsewhere. And then those of us that are from there are like, so what do you call health happening in Europe? What is that called? Just health? So there is a lot of lines that are blurred, and now what is being raised as to, wait a minute, please understand that global health is what's happening in Detroit. Global health is what's happening in New York City. Global health is what's happening in, you know, in Belgium. Global health is what's happening in London. Global health is what's happening in Windsor. Global health is what's happening everywhere in the world. This is not, you know, so global and local is all global, right? And so the lines are being blurred. So whether it's this, which is healthcare that is happening in a community in Accra, Ghana, right? Whether it's this, which is healthcare that is happening in northern Nigeria, whether it's this, which is healthcare that's happening in southern United States of America, believe it or not, right? This is free healthcare, free clinic that has been set up outside to care for millions of people who do not have health insurance and are very unhealthy in what is usually tagged as the richest country in the world, which, like I said, is also the country with the highest debt. So who is defining wealth, right? But again, this same scenario, is this scenario, right? Same here. These are people in, I believe, Virginia that are waiting in line. They've been waiting. They come very super early in the morning, like early o'clock, sometimes the previous day, to stand in line waiting for free healthcare in the United States, right? Is this understanding that 44 million Americans are living in poverty, that in locations where we usually like, well, global health is happening over there. No, it's happening right here. That those dynamics of power, those structural and systemic issues of poverty, of isms, racism, sexism, capitalism, all this business, these are global, truly global geopolitical forces impacting upon people's health and well-being. And it's happening everywhere. So there is a blurring of the lines. And so in the reimagination of global health and the way we teach global health education, this needs to be very concretely said, and which is why those of you out in the audience, especially those of you living in 2/3 of the world, majority of the world, need to be part of the reimagination, the redefinition, the reconstruction of global health. What it's going to be called, because it's probably not going to be called global health in a minute, what it's going to look like, and what it's going to do. So let's talk about reconstructing global health education. And this is a picture from one of my classes. That's me. That's before I had my third baby. So I was like 549 pounds lighter, or for some of you, kilos. I have these 3 little ones, and I now look like a mother. But then I didn't. I was really cute and petite. But now is a whole different story. But this is one of my classes, and I was talking about social determinants of health in global health space in this class. And so I just wanted to give you that visual, okay? And so what is beginning to happen in terms of the reconstruction and the reimagination of global health and the ways that we teach it is to decolonize it. And you all are aware of this decolonizing global health movement, right? And so I want you to put in the chat, what does this mean to you? Just use words, okay? Again, you don't, when I say use words, like what else are you going to use? Pictures? If you can, use pictures. But if you can't, just use like simple words, 1 or 2 words. Like I said, I mean, if you want to write paragraphs, I love, but it's always nice to just have, simple words that just 1 or 2, not more than 3 word reflections on, what this means as we reconstruct, global health and global health education. And so, Shubham, thank you. You said you like my energy and enthusiasm. You are awesome. Thank you so much. Universal healthcare coverage. Yes. Health is for all. Okay. Yes. Non-patronizing healthcare. I love it. Yes. You are still so cute. Thank you, Anan. You're awesome. You're still pretty all. Look at you. Y'all need to come and stay with me forever because honestly, come on, let's be real. I need you in my life. Okay. So absolutely. Okay. And the organizers have reminded me that I'm close to time. And so it's everything you all said. Keep putting it in the chat. Okay. Because I'm going to review this chat at the end. I'm going to ask the organizers to send to me so that I can reflect on, again, when I teach, I learn too. So that's very important to me. So yeah, it means that these mission trips and mission projects, which are 100% a vestige of colonial practice, where folks were on a quote unquote mission to save Black people and natives for Jesus and for making money for white people, right? And making money to develop Europe and Africa and North America, right? Like that was the mission. And many people still use that language today. And the hope is that language, it disappears. We've eradicated that at Wayne. And so that becomes very important, the name and what it does or what it means, right? So that becomes important. And even inside country, eradicating that name. We're not here to save nobody. We're here to work with people in partnership, equitable, just partnership that is centered around restorative justice and places the people we're working with as experts and equitable partners with us to improve their health according to their priorities and their value systems. It's not a mission, right? Right? So we don't do trips. We eradicated that word trip from my institution. Well, when are we having this trip? This is not a trip. You can plan a trip, but you're not gonna conflate this two inside of global health while we're still calling it that. You're engaging in an immersive learning experience where you get to learn from folk to teach you the things, the qualities and the tools that you need to be an effective global health practitioner in the world, period. You're not going on a trip, all right? We banned voluntarism. We don't do that. Not going anywhere and taking pictures to then display everywhere. That reinforces, and I saw someone put in the chat, white saviorism, like that's no. Gotta eliminate that. And of course, this has been brought into sharper focus with the pandemic and the cessation of travel for a lot of folks that come from the Euro-American region that go outside to the majority of the world to do many of these things we just talked about, right? And so put in the chat how you feel the pandemic has emphasized these points. So how has it changed the way that quote unquote global health is practiced or taught in your institution where you're located? Put in the chat. I'd love to learn about that. And it's done that in so many ways. So in global health today there is now this surge, right? This surge of recognition, and the pandemic put in sharper focus that we need, like, we are not doing a good job of representing, role modeling, and teaching about the very dynamics that undergird global health, healthcare, public health around the world, and certainly in our backyard. We are not doing a good job. And so issues of social accountability, power, prestige, privilege, and praxis, which is practice, right? And the application of theory to practice, translation, application, right? All right. The collapsing of this false dichotomy of global and local when it comes to education and practice, and the need to develop a more comprehensive, holistic global health framework that encompasses all these pieces that I'm referring to, right? So we need an educational program that is more intentional about incorporating climate change and environmental justice, equity and justice, talks about poverty and the root causes of poverty, not personal responsibility, but talking about the poverty as a construct, that it is produced by institutions and policies, etc. That talks about misogyny, gender bias, gender-based violence, that talks about homo and transphobia, ableism, racism, xenophobia, aging, econopolitics, ethics, and cultural humility, that centers social and structural determinants of health, that talks about interdependence, intersectionality, bidirectionality, and of course, pandemic and disaster preparedness. That our educational system, global health educational system, has a lot to do to grow, has a long way to go to encompass these pieces. All right, right? And of course, this parallel pandemic that is happening along with COVID-19, which is what the WHO and the United Nations has termed disinfodemic. We are in a disinformation pandemic parallel to the COVID-19 pandemic. And so how are global health folks, practitioners, educators, researchers, advocates, policy decision makers prepared for this, and how are we teaching for our students to be prepared to have the necessary tools to get this under control, right? Okay, and in addition to that, that is related to this infodemic is this massive, and I saw some people put in the chat about folks not believing in their institutions, their governments, what they're saying, and science. There's a huge mis and distrust, and these are two separate things. Mistrust is based on feeling and intuition. Distrust is based on informed judgment. Is that informed judgment? Like, there is evidence that makes me not trust in you, totally justifiable, right? So that's distrust. And untrustworthiness, because it's not enough to just say, well, folks don't trust, folks mistrust. Well, why? Did you do something to them? Is there a history of abuse or non-transparency, dishonesty for a certain community that justifies their distrust? Yes, okay. Well, that needs to be addressed, which is why I referenced a restorative justice model. So you have this also going on. And so the question is, how well equipped are we to grapple with these issues? And how well equipped is our global health educational system and ecosystem to prepare y'all to grapple with these issues? Put that in the chat. How well equipped do you think we are? And why? If we're well equipped, why? How so? And if we're not, why? Why do you think we're not? I want you to think about that, reflect, and put in the chat. So we need folks in global health, as we reimagine and reconstruct global health, who have strong systems thinking and critical thinking skills. We need folks that are anti-colonial and understand what decolonization means and are active in actually decolonizing actively. Like you all said, first yourself and then outside. We need folks that have the skills around anti-racism, anti-oppression, and social justice. We need folks who have skills for advocacy, who are skilled in climate science to ensure climate justice, who are skilled in planetary health, who are skilled in interprofessional collaborative education and practice like you all are. Although I don't know if I have my, shout out if you are in the humanities. If you're on this call and you're in the social sciences, you're in history, you're in anthropology, sociology, African studies, gender studies, shout out and put in the chat, because we need those folks. This is not a medicine or health professional thing alone. We need those people. Shout out if you're a community organizer. If you are an activist, community organizer, you can be all these three things. Shout out and put in the chat. Okay, global health governance and diplomacy. These are emerging fields. These are the skill sets that we need, honey, for today's global health landscape. This is what we need. And the question is our educational system prepared? Folks who know how to weave the basket, who know how to see the connections, connect the dots, understand the intersectionality and interdependence of all things. And they can go ahead and weave. We need weavers, we need basket weavers, storytellers, partners. Okay. So very quickly, because I'm mindful of the time and I've been reminded, you know, this is the skill set that I was just talking about. How do you engage with populations who are oppressed? Do you have skills around trauma-informed, healing-centered engagement? Asset-based, trauma-informed, healing-centered engagement, right? Because you can't just walk up into any community. I don't care even if it's in your country, the backyard, and just start doing, no, you can't assume anything. You need to go there prepared. And so do you have that skill set if you're to engage in what I call JEDI B, which is justice, equity, diversity, inclusion, and belonging? All right, anti-racism, decolonization. If you want to do liberation work, do you have those skill sets? How to navigate, disrupt, transform systems and the values that undergird them. How to ask why. How to conduct a root cause and power analysis and disrupt from there. How to own and create, manage narrative, perspective, voice. Okay. Many of you have seen this image. I'll just leave it here for you to look at. But in the spirit of time, move forward, but it just emphasizes the point. And I put the sustainable development goals here because I want you to look at this with a different lens, as a lens of the empowered majority, the unassimilable majority, the empowered majority of the world. When you review this SDGs, does it reflect the values? Does it reflect the principles that are required to actually bring this about? What does it mean within your context? And it's so important that we contextualize global. You know, we talk about global health, but there is no one size fits all. You have to contextualize it to where you are. And I'm understanding that I'm speaking from a location in the city of Detroit in the US, right, in the state of Michigan, with a background in Nigeria, West Africa. But you all are from so many places, Indonesia and India. No, there's a rich history where you're from. Do you know that? Are you familiar with that? Your own story and the story of the community around you. And knowing that, how do you translate these SDGs from a decolonized perspective, from a reimagined perspective? So what is your context? What is development for you in your context? What does it even mean for you? Not what the UN or the WHO or whomever said. What do your people define as developed? If you have strong communal bonds, familial bonds, is that development? If you have an economic system where people are not in debt, you pay cash for what you have and you keep it and you own it. And if you lose your job today, you're not afraid that anyone's going to come and take your stuff. Is that development? If you have low stress levels, is that development? How would you redefine these things? What is civilization? I want you to put that in the chat, okay? And many of these, as we reimagine and we reconstruct, are going to come up in the ways I've started to see some of you all in the chat say. Universal health care, creating a social safety net, how family-centeredness and communality, how do we translate those value systems, those indigenous, local, contextualized value systems, principles that undergird who we are into policy, into practice as it relates to health, healthcare, and public health? What would that look like, right? And it would look like some of the things you all have said: stronger social safety net, government policies that emphasize environmental and ecosystem justice, climate justice, gender equity, of course, racial equity, of course, equity among those are our LGBTQIA brothers and sisters, primary healthcare that's preventive, right? We will address head-on the roots of liberalism, globalization, and consumerism, and how is the impact, the true whole impact is having on our different locations. So, what would you redefine? How would you redefine global health as it currently exists? What inside of global health as it currently exists would you change? Would you redefine? Put that in the chat, and we'll move on. Okay. So I'm gonna quickly now in my last few minutes talk about what we're doing in Wayne State University to attempt to answer some of these questions. We are not perfect, but we are trying. We are not perfect, but we are intentional. And there's some exciting things coming down the pike of how we are growing and evolving. But as we readily know, there's been this rapid growth of quote unquote global health as a field of study of interest among students. And a lot of, and this is from the US context, colleges and universities trying to, seeking to meet that need. At the same time, a lot of programs are focusing on social justice and community-based strategies domestically and internationally. So you have this global experiences, local experiences that have emerged. However, in that rush, as is often typical in systems such as these, the professional education has not kept pace with these challenges because of fragmented, outdated, and static curricula, and it's produced ill-equipped graduates who reinforce the same problematic dynamics that we are resisting for those of us from the global majority, right? All right, so I refer to us as the global majority, not the global South. We're the global majority. Makes sense to me. And so understanding these gaps, right, that there's a paucity in structured training, preparation, and appropriate oversight and supervision, silos of global health education, research, and advocacy, and that the global health folks in the US have been poorly trained in a number of areas. And there's a wonderful study that came out that looked at this and showed that when it came to program management, monitoring and evaluation, communication strategy, project design, collaboration and teamwork, cultural sensitivity, flexibility, creativity, these areas, that a lot of folks trained in global health in the United States were ill-equipped, okay? So they needed to be an answer to that. And so what we did at Wayne State University is that we created the Global Health Alliance. And the Global Health Alliance essentially is a collaborative community of practice that's multidisciplinary with interprofessional educators, researchers, practitioners, and advocates. And we came together to design a robust, comprehensive global and urban health program centered in ethics, cultural humility, bidirectionality, equity, and social justice. And this is my partner, Dr. Chris Kaufman, who is an ER doc, and we did this together. And this is our board of directors. Some of them are in this picture, not all of them, but you have to always shout out and acknowledge folks who are contributing and doing an excellent job. So these are them: Dr. Amy Curtis, Jeff Van Leer, Aaron Kumar, Laura Klein, Jamie Snell, and Dr. Zervos, and of course myself and Dr. Kaufman. And so with GHA, our mission is fourfold: to educate, to build communities of collaboration, to innovate in global health, and of course, to advocate for equity and justice. Under our educational umbrella is where Global and Urban Health Equity Curriculum, which is GLUE, was formed. And so what it is an innovative, comprehensive 2-year interprofessional competency-based certificate program that provides a structure and framework to guide global and urban health education, study, and research at Wayne State University, okay? And so through mentorship, scholarship, education, and didactics, community engagement, and advocacy opportunities, we designed this program to meet the growing needs of our trainees and faculties across various disciplines who had great intentions, but they really needed guidance inside of a well-structured and ethically designed global health curriculum that is rooted in justice and equity. All right. And I'll skip this page, but understand it has been recognized as really a best practice model, okay? And Yeah, don't worry about this. And so the values and principles that we really espouse is that it's community driven and prioritized, ethical, equitable, just, humble and proficient, culturally humble and proficient, creative, interprofessional, and it focuses on assets. And the other piece is that joy. My purpose in life is to embody joy and fight for justice. To embody joy, forgive the noise, those are my kids, children with children, right? To embody joy and fight for justice. So in everything that I do, I ensure that those two components are represented. And so GLUE, we try to imbue joy in the way that we designed the program. This is just a sample piece. It is competency-based from the CUGH's toolkit, which is available online. And so this is one, it has 11 domains and there are different competencies. So for example, domain 3 is social and environmental determinants of health. That's the domain, that's the topic that we learn. And under that is the competency. So what do we want them to be able to do as a result of learning about social and environmental determinants of health? So I'll just talk about 3A, domain 3A. Describe how cultural context influences perceptions of health and disease. So that's one of the competencies. And then the toolkit is really wonderful. And I'm part of the subcommittee that produced this toolkit. I didn't contribute to this toolkit. I came in after it was produced, but I'm helping support it now. But it provides teaching strategies and resources, and websites, articles, books, and study questions. It's a wonderful comprehensive toolkit for teaching global health. The area that it needs to, this book also needs to be decolonized because it was developed here in the US, in a US, Canada, based setting, and they need more information. It's in English, the language of it. So there's tons of opportunity. And these are just some of the topics, the 11 topics that I referenced, okay? We have monthly seminar series. It goes from August to May, it's 2-year long in the evenings. We have a didactic overview, they get a pre-assignment. There's a guest speaker from the community, from different professional backgrounds from all over the world. And then there's a small group engaging interactive activity, okay? Our partners are local and international. Our local partners are Freedom House Detroit, which myself and Dr. Jamie I talked about earlier, our mentor over this partnership. And inside of this partnership are capstone projects that our scholars work with in partnership with the partner agency. This is Pradati in India, which is led by Dr. Kumar. Samaritas is a houselessness agency that we work with. And First Aid First is focused on community education to be a bystander CPR administrator. All right. We also have different partners in the region in Detroit. So we have Henry Ford Health System, the Global Health Initiative. We work with CUGH. We work with the World Health Student Organization, CISG in Costa Rica, and Child Family Health International. And we're very proud that we created a Global Health Research and Fieldwork Practice Summer Institute that had to go online last year because of the pandemic. And currently we're trying to figure out how it's going to look as things are shifting with the pandemic. We've been very fortunate to disseminate this at various conferences locally and also internationally with CUGH, Unite for Sight, and American College of Academic International Medicine. And we've also published on this. We've also used, of course, social media. So we have YouTube videos. You can find that online. And we're proud of the 3 cohorts we have graduated. And this is our first cohort that we graduate, and they get this beautiful certificate, okay? So we've spoken a lot. I want us to take a minute, I'm looking at the time, to just breathe. Another breath. And I want us to think back on that first case, okay? Now that we've had this conversation, and we think about, this case about certain countries, first of all, hoarding of the vaccine through manipulation of vaccine patents, and their different sort of trade policies and very problematic dynamics at play, right? And then secondly, moving forward to getting another booster shot while there are people in other parts of the world that haven't even gotten shot 1. And while there are people in the same countries who haven't gotten shot one, right? What does that mean today? And you as a global health student, what can you do to address the underlying, undergirding dynamics of power and privilege, right, that are rooted in white supremacy and colonialism? We have to call it out because it is true. And if you don't call it, you can't deal with it. You can't resolve it. And so what I want us to get to that third part, because we talked about react, reflect, engage, and react, and think and act. And you all have been outstanding engagers. Oh my God, amazing. Thank you so much. I can't wait to go through the chat. And now this is a conversation about action. And so what can you do? And put this in the chat from an action standpoint to take the reimagination of global health from imagination to construction in its name, in what it does, and what it looks like, to begin to address specific issues such as vaccine inequity and vaccine injustice with the pandemic. And so with that, while you think through, I want to thank you for this time. Thank the organizers. It's right at the minute of 11. You can email me. You can check GHA and GLUE out on the website, wsugha.org. You can email me, innodim@wayne.edu, and you can follow me and/or direct message me on social media. And this is my handle at INNODIM at Twitter and Instagram. I'm also on LinkedIn. And so thank you again. And if the moderators are okay with entertaining some questions, I'm very happy to stay and take them. And while you're thinking about that, I'm going to start looking at the chat. So thanks again.
Thank you, Dr. Opara. That was very insightful presentation. And I have to tell you this on behalf of everyone. We loved your energy. We loved your vibe. We loved your positivity. And thank you again for this beautiful, wonderful presentation that you have given us. So we have compiled several questions asked by our participants in our registration form and the chat box. So if you are all right with that, can we go ahead?
Mm-hmm. Of course. Thank you. And thank you so much for the kind words.
Yeah, oh, my pleasure. So the first question. The first question is from Mikhail Atip, Indonesia. Their question is, how should we implement global health in the medical curriculum of medical schools in the global south?
And so the question is, how should we implement global health in medical curricula of medical schools in the global health south? Pardon me. I think the first step, thank you, Mikhail. Thank you. And I hope I'm pronouncing your name correctly. Okay, names are important. So if I mispronounce it, please teach me. Put it in the chat with the phonetic spelling, okay? Names are very important. So I would say the first step is in the global majority, because again, I don't use the word global south. In the global majority, we need to first of all define for ourselves what health is or what global health, what does it mean for us? So you will have to define for yourself in Indonesia, what is your community definition of global health mean? What does that mean? I think that's the first step. And that's why this talk is titled Reimagination. These are very fundamental transformations. We're in a transformative time. So it is an opportunity we have to redefine the things that we have accepted or believed to be true. And that's just how things are for so long. So first of all, does the term even global health make sense to you? Right? So you in your community would need to define what that means. And then based on that definition, that reimagining and definition, then go through the process, because every medical school has sort of like a curriculum process. I know at Wayne State, if you have any curricular changes or proposals, there's a committee on curricula, right? That you have to sort of go through. There's a vice dean of medical education that you can, if you have, so whoever is on top of, who is in charge of your medical education, I would first of all talk to them, let them know sort of what you're thinking, get that buy-in, get that partnership, and then walk through the process. Find out in your school, what is the process to implement curricular change, right? And get that buy-in and support from your dean or vice dean or director or whatever that position is in your school and in your context for how to then engage in curricular change. But before you even start that process, you have to be very clear what that looks like and what that means to you. You have to get you have to figure out who are the stakeholders, get the buy-in of all stakeholders. And by stakeholders, the first and most important people are the communities we serve. They are the number one. What are their thoughts on the ways that the doctors or healthcare professionals that take care of them, what are their thoughts on what are the qualities that they want from them? What does that mean and look like? And then from there, once you create that buy-in, you create that swell of support, you're very clear on the imagination and what it means and looks like. You talk to other folks that are doing the same work and you build that coalition. And inside of that, you can then start the process of reviewing your curriculum as it currently stands, and then how it can adjust or change, or how your proposal can then be integrated into your medical school curriculum. So I was, so that's what I would say, and definitely lean on the students against COVID to as a support, because I know there are wonderful leaders who have done similar things at their institutions that can offer a lot of insight.
Thank you, Dr. Opara, for answering our questions. And all the remaining questions will be sent to Dr. Opara personally, and we'll get the answers then. And I have to
Monica, if you don't mind, just very quick, because I see how to join Glue. Just go to the website, Ken and Victor. Just go to wsugha.org and and go and just start from there. And you can also reach out to me. So some of these things, just reach out to me on social media. Follow me, join me, whatever it is, and so that you can DM me, and I'm happy to connect you, okay, and go from there.
Thank you again. And it has truly been our honor to host you in our session. We believe the talk was very insightful for our participants as we learn more about global health and the social and the education regarding that. We would like to take a group photo. So I request all the participants to open their cameras. We'll wait for a few more seconds.
Okay, I think I can help take the picture. So 1, 2, 3, everyone. Okay. Yeah. Done. Okay, I'll give back to Monica.
I was copying Dr. Vishnu. I saw Dr. Vishnu with the peace sign. I said, that's so cool. I'm going to do the same.
Thank you very much, Dr. Opara. I believe next up we'll go to the next speaker. Thank you once again for your time. Your talk is very inspirational. So next up is Dr. Mohan. Dr. Mohan, we're firstly very sorry to keep you waiting. Thank you for being here. The moderator will be Monica, and now Monica, the time is yours.
Thank you, Adriana. The next talk will be about the globalization of health and actors in global health, which will be presented by our honorable speaker, Dr. Nitin Mohan. Dr. Nitin Mohan, MD, MPH, is an assistant professor at Western University, Canada. He is also a partner and physician epidemiologist at a private public health consultancy firm and research think tank called ETIO. which is based in Toronto, Canada. He formerly worked for the Government of Canada at the Public Health Agency of Canada, where he was physician epidemiologist with the Center for Foodborne, Enteric and Zoonotic Infectious Diseases, as well as Surveillance Coordination Unit under the Infectious Disease Prevention Control Branch.
Thank you for that kind introduction. Is it possible for you folks to give me the opportunity to share my screen, or will you be sharing it on your end?
We've given you the permission to share the screen. Could you please try?
So I'm logged on two computers.
Okay.
The login without my picture. If you can provide the permissions there.
We've given you permission. Do you mind?
Got it. Perfect. Thank you.
Greetings, Dr. Mohan. Thank you for sparing your time to share your knowledge with us. The stage is ready for you.
I appreciate it. Oh, that's not what it's supposed to look like. Give me 1 second, folks. Sorry, folks, give me 1 moment. My computer seems to be acting finicky today. Are you folks able to share my presentation on your end, perhaps? Is that possible?
Yes, it's possible.
Maybe we should try that method. I seem to be having some difficulties on my end. So while we set the presentation, I'll just take this moment to acknowledge my previous speakers. I wasn't able to listen to the first session, but I caught the ending of the last session and absolutely blown away. And I can't echo the sentiments. You know, it's almost sad to say, but this is an exciting time in global health for a few reasons. I think there's a momentum that we built, and unfortunately, it's taken a global pandemic to do so. So my hope is to share my thoughts to you folks on how I view globalization of health and the actors. Before I begin, my name is Dr. Nitin Mohan. My pronouns are he and him. I'm talking to you folks from Toronto, Canada today. Our ETIO offices are located in the territories of the Anishinaabe, Huron-Wendat, Haudenosaunee, Ojibwe, and Mississaugas of the Credit First Nation. We also recognize the past and present contributions of the Métis, Inuit, and First Nations peoples that continue to have a hand in shaping and strengthening these communities and our province and country as a whole. So I'm currently a partner at ETIO Public Health Consultants, which is a private public health consultancy firm. There aren't too many of us in the world. So I'll give you folks a bit of an origin in terms of why we decided to go this route. Prior to launching this firm with two partners, I worked for the Public Health Agency of Canada, which is the equivalent of our CDC. And I was working their surveillance coordination unit and also the zoonosis division. I spent time tracking infectious diseases across the country. We would create systems that allowed us to gather data in what we were hoping was an equitable manner. And I say hoping because in 2020 and 2021 is when we started to collect race-based data here in Ontario. And I think that sort of highlights how I view globalization of health. If we only started to collect race-based data in 2020 or 2021, we have to question what the programs that were previously created, who they were created for. And then it makes us question who they were created by. I'm also an assistant professor at Western University under the Schulich School of Medicine and Dentistry. I teach two courses in the Masters of Public Health and the Masters of Global Health program. 5 years ago, when I started teaching, we would be lucky to have 15 students in our Global Health program. I think this upcoming year, we're expecting the largest cohort, and I think we should be at around 50, and we anticipate having much higher than that in the coming years, which is a welcoming sign, I think. The world needs as many global health advocates as possible moving forward. Next slide, please. So I tend to view questions and topics as from a macro level. What is the new normal? When we take a look at the new normal in the midst of a global pandemic, and I want to acknowledge my position in terms of where I am situated in the world, being in Toronto, Canada, having access to vaccines, having access to healthcare, medicines, minimal disruption to our livelihoods in comparison to the global community. In Canada here, we're discussing booster shots, whereas there's many countries across the globe that have yet to administer one dose of the vaccine. People here have the luxury to protest against the vaccine. They have the luxury here to protest against public health measures to protect the community as a whole. I think for those of us in the global health field, for those of us who are committed to the very important work of diversity, equity, inclusion, for those of us who want to highlight the systems and structures that have made populations vulnerable, these realities are difficult for us to acknowledge. But I think they're important conversations, and I'm encouraged that we're able to have discussions like this. You folks have seen this slide, many times before. I want to highlight specifically Goal 17, partnerships for the goals. If you folks haven't already, and I trust many of you have, I would take a dive into the MDGs and understand how we went from the MDGs to the SDGs. And this is a monumental leap forward. However, there's still much work to be done. Unfortunately, I think we're reaching a tipping point in terms of our climate issue, in terms of social and systemic issues and structures that need to be reimagined, reconstructed, in some cases torn down. And so I think the partnerships for the goals moving forward sort of centers and highlights how we view globalization and health. Next slide, please. So I want to orient the conversation moving forward. This is a quote that I start my lectures off with in the first day of class, and I think it's something that should set the tone for how we view, all topics in global and public health. We have lived our lives by the assumption that what was good for us would be good for the world. We have been wrong. We must change our lives so that it will be possible to live by the contrary assumption: what is good for the world will be good for us. And that requires that we make the effort to know the world and learn what is good for it. And I think this is quite interesting. And again, if you look at a macro level and we take a look at population dynamics, countries that previously were viewed as third world or that are transitioning from low to middle income countries to emerging economies are in this zone where I think disproportionately they may be blamed for certain issues, such as our climate change issues and the spread of infectious diseases. Whereas we in the northern part, or what was considered the Western or developed world, quite frankly, disproportionately contribute to things like global warming and issues related to the lack of global health equity. And so when we think about globalization of health, I think it's important to acknowledge that it's not globalization from the West going to the East. I think there is much that can be learned from our perspective, in terms of practices in other parts of the world. And that's what I really wanted to highlight in terms of the globalization of health. Next slide, please. So you folks must have seen this already as well. When we talk about globalization of health, we have to understand what we mean by health. So the WHO states that health is a complete state of physical, mental, and social well-being, and not merely the absence of disease or infirmity. The Alma Ata Declaration adds to that: health as a socio-economic issue and as a human right. As a human right. Again, when we take a 50,000-foot view of how the pandemic has affected the globe as a whole, how countries have the partnerships that have led to phenomenal initiatives like the Sustainable Development Goals, those partnerships have been paused in some regards. Again, we're talking about booster shots here in Canada when other parts of the world haven't even received one shot. So the socioeconomic issues and human right as a definition of health, I think, is quite important for us to sort of understand how that's played into part. And I think that sort of also underscores our perspective here as a private public health consultancy firm. So I'm sure it's been well documented. Public health, global health has very much strongly tied to the political bonds. Oftentimes we're at the mercy of politicians, of certain election cycles, and we have to navigate these things and take the victories while we can, right? So whether your government is conservative or whether it is more so on the liberal side, we have to be quite nimble and take advantage of what we can. That, in my opinion, was the hallmark of what we've done. And I think at this point in time, it's up to us in global public health and you folks as future leaders in the field to really take into heart what public health is. Upstream, proactive, preventive. And I think we can be proactive now coming out of this pandemic, although it might be premature to say we're coming out of it. We still have a bit of a road ahead. Next slide, please. So at this point, many of us, after these definitions, may still have individual perspectives of health. And this can be defined in various and contrasting ways, depending on one's standpoint, perspective, or values. When differing worldviews and disciplines come together, the process of negotiating health is complex. I seem to be doing really well at highlighting problems that I'm not providing many solutions here. It pays in life to know how to think and what to think about. What I'm trying to do is orient our mind frames in terms of how do we approach things moving forward. And I'll give you folks a little hint in terms of an approach that I've used, I've advocated for my students to use, and our employees at ETIO, is that we ask that every problem, every situation be viewed from a lens of empathy. So when differing worldviews and disciplines come together, the process of negotiating health is complex. That much we know. Cultural norms may differ from one region to another region. Social development, developmental, all these issues are specific to countries and regions. But through the lens of empathy, I think we can understand ways in which we can collaborate and create partnerships that are beneficial while acknowledging cultural practices of other regions of the world. I think one thing that isn't for debate is planetary health. Regardless of where you live, what you do, and when we talk about globalization, whether it's trading with goods or services or healthcare services, if we're truly talking about globalization, that conversation has to start with planetary health. Next slide, please. The achievement of the highest attainable standard of health, well-being, and equity worldwide through judicious attention to the human systems, political, economic, and social, that shape the future of humanity and the Earth's natural systems, that define the safe environmental limits within which humanity can flourish. Put simply, planetary health is a health of human civilization and the state of natural systems on which it depends. I highlighted equity here because I think this is quite important in terms of everything that we do moving forward in global health. If you folks are really interested in understanding how global health is shaped, and I think the previous speaker did a wonderful job highlighting some of the gaps that global health professionals have, take a look at where the global health leadership emerges in the world. Take a look at the gender imbalance in global health leadership as well. And back to my previous point is, if in a place like Canada, where we just started to collect race-based data, who were the programs created for? If our leadership doesn't reflect the communities, and if our community is increasingly global, then our programs that we created, the globalization of health, truly isn't globalized. Next slide, please. So global health is a systems thinking field. It's a critical thinking field. Oftentimes, folks can't see the forest of the trees. This is a fun slide that I'm sure many of us in the global health field have used to underscore this topic. But really, we need to take a macro level view of what is good for us, and that is first determined by what do we share. What are our shared perspective? What are our shared goals? How is the best way to efficiently and effectively create a globalization of health? And again, it's not just from the West to the East. I think that we have to reconfigure our mentality here in the Western world and draw from practices from the East and other parts of the world. Next slide, please. So when we talk we tap into global health systems. We talk about them as a constellation of actors, individuals, and/or organizations whose primary purpose is to promote, restore, or maintain health, and the persistent and connected sets of rules that prescribe behavioral roles, constrain activity, and shape expectations. Among them, such actors may operate at the community, national, or global levels, and may include governmental, intergovernmental, private, for-profit, and/or not-for-profit entities. There's a lot to pack in this slide. What global health is today isn't what it was 30 years prior. What global health will be tomorrow isn't what it is today. It's a new world. And there's a good to that and there's a bad to that. I think the negative side to the new world we're living in is the disinformation epidemic that was discussed previously, which is a battle that we're fighting. It's as one of the constraints we have in the public and global health world is that we're very much rooted in evidence and data. Sometimes there's gaps in the evidence and in the data, whereas disinformation can be spewed at a rate that is much faster than we can counter it because we like to get the evidence and data. We go to peer review. We have these systems in place that are generally benefiting the overall discipline. It's a new world. You folks are able to create initiatives. You're able to attack global health. You have institutions like the Bill and Melinda Gates Foundations. You increasingly have private entities that are entering the global health field. Anything or any initiative that has population level impacts has a global health responsibility. Okay, so that includes private corporations, that includes governmental bodies, that includes non-governmental entities, right? So who are the actors in global health today are not the same as they were previously. It was very easy to define actors 10, 15 years ago. It's very different to define the actors today. And what we're seeing is a pushback against what was considered the norm, what was considered certain practices that we were meant to practice, that were standardized across the board. And in some ways it's very exciting, and in some ways it's also very scary. Next slide. So typically, when we talk about global health systems, there's 5 disciplines that we like to hit home. So transdisciplinary, knowledge to action, participatory, systems thinking, and sustainability. Okay. Good programs have all 5 of these metrics in place. A strong global health professional will be rooted in these 5 disciplines. Okay. Again, we must ask ourselves how to build in equity in each one of these practices, right? Systems thinking through an equity-based lens, sustainability through an equity-based lens, transdisciplinary through equity, knowledge to action, and participatory as well through equity. Next slide, please. So as discussed, the traditional actors in the global health stage, most notably the national health ministries and the World Health Organization, are now being joined and oftentimes challenged by an ever greater variety of civil society and non-governmental organizations, private firms, and private philanthropists. In addition, there is an ever-growing presence in the global health policy arena of low and middle income countries such as Kenya, Mexico, Brazil, China, India, Thailand, and South Africa. This is truly a new world if there ever was one. This is truly an opportunity for collaboration and meaningful partnerships above and beyond what may have been perceived as tokenism in the past. We truly want stakeholder engagement. We truly want to build partnerships. And I think what's exciting from my experience, having worked in the governmental side and now the private side, is there are clear linkages that we're able to join that weren't previously explored. Next slide, please. So if there's one slide that I would ask you folks to sort of commit to memory, is this one right here. What we want to aim for is transdisciplinary at the top. Oftentimes where we get sort of the bottlenecks in global public health, from my experience, are in the multidisciplinary field. Going from multi to interdisciplinary is some of the largest challenges I've had. And a few instances where we can get to transdisciplinary, we truly have a cohesive system that is efficient and effective for all those that are involved. My personal hope was that coming out of the pandemic, a transdisciplinary system is something that the global community would lean towards. Sharing of resources, sharing of information and data sets that are de-identified and patient protected. Again, these conversations are ones that we can have in our position here in North America, where we have an embarrassment of riches in some ways. But I think these are conversations that are very important to have as we set the systems moving forward in terms of data sharing and de-identifying patient information for the hopes of a transdisciplinary system that utilizes the strengths that we have here in this part of the world, as well as the strengths in other parts of the world. Next slide, please. So here's an example of transdisciplinary systems and programs that are working in conjunction. I'll let you folks take a quick look at this slide, and I won't read every section of it. What I will highlight is that we have a partnership of foundations, private sector, and non-governmental organizations, as well as major governmental organizations. This is what we'd like to see in an ideal situation. And I'm being very flattering here. There are some downsides here, but what I'd like to do is paint a picture of possibility at this moment. We'll just leave the slide on for about 30 more seconds. If you can just go back to 13, please. Just so folks can get a full grasp of the partnerships that are in play here. So we're truly seeing the multi, inter, and transdisciplinary work in real time with this slide. If we can go to slide 14 now, please. So this is where it gets a bit tricky. When we talk about actors in global health, when we talk about actors in the globalization of health, there are some good and some bad, okay? So the rise of multiple new actors in the system creates challenges for coordination, but more fundamentally raises tightly linked questions about the roles various organizations should play, the rules by which they play, and who sets those rules. And this is a rhetorical question, but can you folks guess who sets the rules, which organizations have more sway, who has more pull? I'll give you a hint. Oftentimes, the level of funding and the monetary funds available add to the weight of the leading organizations. So actors may exercise power within the constraints of international institutions in hopes of achieving benefits and shared objectives. That would be ideal. This helps explain why actors are willing to fund multilateral initiatives, such as the ones that we previously shared. On the other hand, powerful and financially independent actors, such as national governments, may elect to use their resources to influence the outcomes of multilateral initiatives or create bilateral ones. So again, if it's the nations themselves that have the ability to direct the health outcomes, then the question becomes is who these leaders are working for. Who do they represent? Are they truly reflective of the communities that they serve? The lack of clear set of rules that constrain distortion of priorities by powerful actors can threaten less powerful ones. As a case in point, despite widespread support for its overarching goals, there is considerable discussion in some cases, even unease and some tension around the prominent role played by the Bill and Melinda Gates Foundation, whose spending on global health was almost equal to the annual budget of the WHO. So now we're talking about an entity that, it's again, there's good and bad. There's phenomenal work that the Bill and Melinda Gates Foundation has done. We've made strides in global health that we weren't able to do without this foundation. But when you have a juggernaut that has a budget this high, the ability to sway program priorities, the ability to have that much influence on low to middle income countries, in some ways is quite problematic. And without a clear set of rules, constraints, and a protocol or system in place, what you have is an ebb and flow of systems. And when we talk about equity, not to, again, I'm not questioning the equity of these foundations, but when we take a macro level approach to this, we have to think about how best to utilize resources for the global totality of our communities. Next slide, please. Low and middle income countries versus high income countries, okay? Take a look at the percent population, the percent of global health leaders, and the percent of degrees obtained in those countries. Okay, there's a clear contrast between high and low to middle income countries. And this, in my opinion, is quite problematic. If you folks are interested to dive into this, I would further ask you folks to take a look at organizations and global health leaders that have been given positions to identify as women. If we're talking about true globalization of health and understanding who the actors are, if we're not rooted in equity, I'm not sure how much progress we can make. At times, it'll feel like 2 steps forward and 1 step back. Okay. There has to be a way for us to approach global health leadership, global health programmatic organization in a way that is rooted in true diversity, equity, and inclusion. Next slide. So this is the last slide that I have, and I think this is quite important in terms of what steps that we should take moving forward. So many have expressed doubts that today's global health system is remotely adequate for meeting the emerging challenges of the 21st century. New thinking is needed to deal with such key issues. There's a set of 5. I'll quickly read through them. I won't read the entire sentence, but feel free to go into them. But setting global health agendas is quite important. Okay. We need to figure out a way to coordinate our resources in a way that is truly proactive, preventive, and upstream. Okay. In the midst of a global pandemic, where no one is safe until everyone is safe, if there was ever a time to build upon this, it's now. Ensuring a stable and adequate flow of resources for global health. When you have actors and entities as big as the Bill and Melinda Gates Foundations or other private sectors, there's truly a fear that one day those funds may not be available. So if we're thinking about sustainable initiatives, what does that look like? Ensuring sufficient long-term investment in health research and development. Okay. This goes without saying. It's something that that I think we've made strides for across the world. Working with many countries, I can tell that there is a clear want and actionable steps that are being taken here. Creating mechanisms for monitoring and evaluation and judging best practices. Okay, this is sort of where I think we have to be very mindful of how do we evaluate and judge best practices? Are we taking the Western approach? Are we taking the metrics that we use here and applying them to other parts of our global community and saying, well, you know what, based on our metrics, this is not working effectively? I think that's very important for us to understand is what are these metrics? What is the data that we value? What is the outcome that we want? Learning lessons from the enormous variance in effectiveness and costs of various national and international health systems. Again, in a one-size-fits-all, I think this can work. When we factor in the social determinants of health, cultural variances, and again, planetary health, I think this becomes a bit more problematic, but I don't think it's impossible to do. Can we go to the final slide, please? So folks, this concludes my lecture. I'm not sure we can get into globalization and actors in a session like this, but I hope I was able to provide a broad level of vantage points for you folks to look at. I'll take this opportunity to talk about sort of some of the work that we do at ETIO and some of the work that my program does at Western University. Our students at Western University who are enrolled in the Global Health Systems program, they spend a year tackling initiatives across the globe. Our program is rooted in Sustainable Development Goals. We have partnerships with lower middle income countries where we set community-based research. And what community-based research really means is that we conduct and work alongside communities to understand what can be done from the perspective of the community. The community is the largest stakeholder. At ETIO, we work with many low to middle income countries and further international partners, creating surveillance systems to track health, specifically infectious disease outbreaks across the world. My personal viewpoint, and this is clearly biased, is that there is a future for public and private entities to work in unison to attack global health issues. But I strongly believe that any globalization of health cannot start or be discussed without equity being the root of all of our approaches. I'm going to pull up questions right now. I'm not able to view them right now, but this concludes my lecture. I appreciate you folks giving me the opportunity to chime in here. Just a quick shout out to the Students Against COVID. This is a phenomenal initiative. One of our analysts at ETIO also is a key contributor for SAC, and I can't give you folks enough kudos and acknowledgement for the work that you're doing. And it's quite exciting for me and my colleagues, and I think all of us in the global health field, to see the new wave and the new generation of folks who are as passionate about this field as we are. In order for us to continue to build the momentum we've created, and to push further, it's folks like you all that are going to push the field forward. Don't be afraid to take risks. Again, be rooted in empathy, and understand that we're all connected. And so when we create initiatives that are holistic, culturally sensitive, rooted in equity, diversity, and inclusion, we're moving in the right direction in terms of achieving our final goal. I'm happy to answer questions right now, and I'll try and pull up the questions that were asked in the chat group. So I'll highlight one question, and I apologize if I miss any other ones, but someone asked how we as a younger generation, not stakeholders, who has power, ensure the long-term investment in healthcare that we have now. Like, I guess my interpretation is you folks identifying as perhaps younger, and if you perceive yourselves as not having as much power to enact change, how can you ensure that long-term investment in healthcare is sustained? First of all, I think initiatives like today is the first step. The fact that you folks are interested and you're learning about global health and you're curious to know what can be done, I think that's the first start. Depending on your country of origin and the political landscape, here where we are, we exercise our right through voting. Oftentimes you can mobilize as well and ensure that the community has the initiatives they need. And then I would also urge you folks to not be afraid to reach out to private entities whatsoever. From my experience, we've worked with companies that I would have never thought had a global health passion, or they would make funds available for global health initiatives. And sometimes it's just a conversation, trying to help an entity understand why their product that is population based in terms of the impact it has a global health initiative as well. So whether it's extracting funding from that company to get a grassroots movement started, whether it's getting resources from a company to ensure that other regions have access to it, I think there's many opportunities for you folks to do that. But I wouldn't view yourselves as any less capable or any less important. The reality is that each one of us is part of the global community, and this pandemic has shown that, right? That each one of us, regardless of where you live on the planet, is part of the global community. And the hope is that this siloed individualistic thinking is no longer part of our future moving forward, right? That the borders that we put up, the boundaries that we put up, they become free flowing. We understand how health works across cultures, across societies, and across the planet as well. Are there any other questions I can answer, folks?
Thank you very much. I'm taking over from Monica because of technical issue. The next question would be from Frank from Malawi. So how do you ensure that people from low-income countries with less resources like Malawi are getting involved in activities regarding global health?
Sorry, can you repeat the last part of the question, please?
So how do people in low-income countries can get involved in global health activities, considering the global health resource is lower in such countries?
So that's a great question. I imagine many other folks are working on this as well, including my colleagues, but there's a concentrated effort in creating standardized materials across cultures and languages that are made online, that are free to access, and that are made in or created in a language that is easy to understand. So not necessarily technical heavy documents where folks that don't have an MPH or a Master of Public Health rather, or a master's degree are the only ones able to understand it. Documents that are created in a readable manner. There's a clear push for this. So my hope is that you folks are able to access this material sooner than later. And then I would also reach out to your local public health units. Part of our job in public health is to ensure that the population has the correct information at the correct time, right? That's really what we need to be doing is ensuring that people understand what the current landscape is, what the issues are, so they can make the most informed decision. And again, initiatives like this are wonderful. And to piggyback off the previous speaker, wonderful point is that the disinfodemic issue that we're having. One of the reasons I imagine that we're experiencing this, and there are many, is that people just don't have a strong grasp of things like infectious diseases, of planetary health, of diversity, equity, and inclusion. And in some cases, it's through a lack of knowledge, and in other cases, it's through a position of power that they feel is being threatened. So, to not to steer away too much from your question, but in terms of materials, I would surely reach out to your local public health unit. And then I would keep an eye out in terms of more materials being made available, because from my perspective, I know firsthand that we're working on materials such as those.
Dr. Mohan, if it's okay, there's one more question about your content. Can you perhaps clarify the differences between multidisciplinary, interdisciplinary, and transdisciplinary?
I think the easiest way to clarify it is that in transdisciplinary, you're not aware things mesh cohesively. It's almost as if you're walking and talking and thinking at the same time. You don't walk without thinking. I guess the opposite would be I'm walking and I'll stop to think. Then I'll walk again and I'll stop to talk. This is happening just cohesively without you understanding it. So you have partnerships, you have expertise, gender inclusivity, perspectives, and things are just working in unison. That's a transdisciplinary program. Can I answer one question real quick that I think is also really important? Basma asked if I think there's a potential for real change, or will it be slowed down by bureaucracy? Welcome to global public health, folks. So this is sort of the lives that we've been living in. And again, I think at times it's quite frustrating. But if ever there was a tipping point, if ever there was an opportunity for us in our field to wave our hands and shout loud and say, this is the time to get these systems in order, it's now. So bureaucratic red tape is something that I don't know a world of public and global health that is not linked to this. This is another reason why I decided to go the private route, is because we want to avoid that. And again, this is a system of our societies where if we require funding for an initiative, that funding has to be approved by the political powers that be. And the political powers that be essentially have their powers based on who votes them in. So depending on the community and what their priorities are, that voting will determine funding. So an example is here in Canada, we're a quite wealthy country. Our data tracking systems in some cases are done by fax machine and paper, right? So we don't have a centralized data system. If you're in one state or province and you have a certain level of COVID cases, I'm not even aware what the city next to me, what their numbers are, because our systems are not connected. And this is often because the funding has not been made available, because if you try to explain to a community of 2 million people that I think we should invest in our data tracking systems, because 10 years from now, we'll be much better off to deal with a potential health emergency, as opposed to, I think we can spend $10 million right now on improving our roads. Now they're both important, right? Like road safety is important, but most cities will say, let's do what's going to help us right now. And in global public health, we tend to work in a proactive upstream manner. That's what public health and global health, that's when we really shine. It's when we prevent and we're upstream and we're thinking about, what's coming down the line. When we have to react, like much of this pandemic, where we're working behind, we're working after an initial threat, it's very hard to catch up, right? It's very difficult to get to that point where we're being proactive. Vaccinations are the first sort of tool or weapon that we've had that allow us to get ahead of the virus, right? And an example is that even in a world where we have vaccinations and we have these tools, you have pharmaceutical companies that have not made the patents available. You have countries that are hoarding vaccines, like we are here in Canada, and not administering them to low to middle income countries. So I think the bureaucratic process of public health will be there. But I think the tides are shifting. So I don't think it'll be a quick change, but I do think the change will be happening. And I have time for one more before I have to go. Forgive me, folks. I'm being called in for federal COVID meeting here in Canada, so my time's a bit restricted today.
Okay, we have one more question that is from Argadeep Das from India. He is a chemical engineering student, and he is asking what will be the role of chemical engineering student in global health.
So I can tell you, I think engineers are needed in almost every facet of what we do. I started off the lecture saying that I'm really good at identifying problems, right? I think that's one thing that we get very very keen at doing in global public health is, I think there's a problem here. There's a problem here. That's great. And we have in some ways, some broad perspectives on what to do. And we're getting really, really good at sort of becoming nimble here. I can tell you in terms of engineers, when it comes to problems such as understanding the airborne and aerosol transmission of COVID, we didn't understand that until we reached out to engineers, right? We reached out to mechanical and chemical engineers and said, hey, there was a bunch of epidemiologists and doctors sitting there, and we're doing all our models and we're getting all the data and we're doing everything, and no one's thought to say, hey, why don't we bring the engineers in and the physicists and understand really what's happening with the particles, really what's happening with the airflow, what happens with humidity. So when we talk about transdisciplinary, this is what we're talking about, right? And I think global public health for a large, I'm relatively, I'm less than 10 years in the field, but I feel like I've been here my whole entire life. And many of us who enter global public health, there's sort of a light that turns on, where once you do population level health initiatives, it's very hard to do something that's acute, and not to take anything away from our acute care colleagues, but transdisciplinary. So whether you're an engineer, whatever sector you're in, there's definitely a role coming, in terms of the future with infectious diseases that we are on the horizon, mosquito-borne diseases, air quality issues. There is a huge role for chemical engineers and engineers of all type, as there are with computer programmers and coders, as they're all with the community leaders and religious leaders. Like everyone is as important as the next person in the global health field. And I think if we work together, we can truly make progressive change.
Thank you very much, Dr. Mohan, for the very insightful presentation and also the answers to the many questions asked by our participants from all over the world. Thank you once again for your time. We would like to take a bit more of your time, if it's okay, to take a photo of all of our participants. So if the participants can please open your cameras.
Sure. I'll put my email and my LinkedIn information in the chat for folks who are interested. I'll provide my university email as well. Happy to take a picture. And again, really excited to see future initiatives from Students Against COVID. And kudos to you all. I mean, this is what we're hoping for in global health, is people taking initiative, putting your stamp on it. This is a shared discipline. There is not one person who owns or leads global health. We're all part of it. So continue doing the good work you folks are doing.
Thank you very much for your kind words, Doctor. So I'm taking the photo now. 1, 2, 3. Okay, kindly wait for a second. And one more time. Thank you very much. I will send the photos to you later on through email. Once again, we're very grateful that you give your time to speak here. Good luck on your future endeavors, and we truly hope that we can collaborate with you again in the near future. Thank you, Doctor.
Anytime. Yeah, anytime. Please don't hesitate to reach out. I'd be happy to collaborate. Take care, everyone.
Yeah. So next up is from Dr. Mazin. So I will be introducing him a bit first. So first of all, welcome, Dr. Mazin. Thank you for staying in our Zoom since almost from the start. We're very honored to have you here. So Dr. Rafael Mazin, MD, MPH, specialized in community-oriented primary care. He is formerly a senior advisor on HIV and STI and viral hepatitis with the regional office of the World Health Organization for the Americas, or the PAHO WHO. Dr. Mazin has more than 40 years of experience in the field of promotion of sexual health and prevention, control, and comprehensive care of HIV and sexually transmitted infections. He is currently active as an independent consultant and a mentor of young professionals with international program network. So, Dr. Mazin will speak about the imaging effects of disinformation and misinformation to pandemic responses. Um, I will please kindly bear with us for a moment.
Rus Beheir, Assalamu alaikum, good morning, bonjour, buenos dias, bon dia, guten morgen. I'm very glad to be here with you. It's a big pleasure, a big honor to share with you some experience accumulated through the years and some additional learning I have had in the last couple of years with the development of the pandemic. I have to confess to you that going through the pandemic made me live again all the experiences of the epidemic of HIV. It felt so similar because when the epidemic of HIV, we started hearing about the findings made by clinicians, by the scientists, but all that information started permeating through the grapevines, and we heard a lot of disinformation and misinformation about it, and we were not clear what was true and what was distorted or false. So one of the commitments I had in the World Health Organization was, in addition to working on prevention and on provision of comprehensive care, was to figure out how information was created, which were the sources from the information was coming from, how the processes created events in which people acquired some um, uh, capacities, abilities to protect themselves, and what was completely distorted. So that's when I learned the concepts of misinformation and disinformation. But I'm going to talk about that in a very, very short moment. Because first of all, I want to mention to you that when we talk about information, we have different levels in which information is happening, or different circuits of information. In public health, for example, we have a circuit which is revolving around healthcare authorities and decision makers, policy makers, who define which will be the policies to be implemented and the measures that need to be in place to contain a health threat. Accurate and dependable information is critical, is a groundwork to create this base on which health actions will be implemented in a country or in a local. And with this, the authorities create what is called a strategic plan. You certainly have heard the concept of a strategic plan. A strategic plan is not created without strategic information. And what's strategic information? Is the information that has been obtained from a source which is credible, that is accurate, that is precise, that we can trust on to establish that base on which we will build the public health action. I hope I'm making sense. But this is one of the circuits in which we see information being obtained, processed, and diffused. We have a second level, and the second level is the level of the healthcare systems, in which all the know-how is used by the clinicians to know how deal with a pathology or a new a health challenge and treat people accordingly, or to contain a problem accordingly. And then there is another level to which I will refer in a moment, which is the information circulating among the general public. Sooner or later, we learned about the nature of the problem, and we expect to use that information to protect ourselves. And this is where a lot of problems arise. So first, following transparency, please. As I said before, do I have the... Can you pass the following transparency, please?
Manahil, can you go to the next slide? Well, I think our moderator is having a network issue. I will.
Do I have it?
Yeah, unfortunately, our moderator is currently having networking issue. I will do it. Oh, okay.
Okay, so yeah, it's all something happened, but never mind. Never mind. We can communicate without transparencies.
I think it's working now. I think the slide is working now.
Yeah, but all the letters are disarranged.
Oh yeah, we're so
something
sorry.
happened. Yeah, that happens sometimes, which is one of the events that may occur when we are trying to convey a message. Never mind. But when a country is trying to establish a national plan to face a threat like COVID-19, they, as I said before, develop harness strategic plans. And the one strategic plan consists basically of two columns, two very important columns, which are containment, which is all the actions and strategies intended to minimize the transmission of the pathogen, in this case of SARS-CoV-2, which is the virus that causes COVID. The containment is the action more important. But once the virus is inside the community, it's important to implement something called mitigation. And mitigation is intended to reduce that dissemination within the community. Let us try to pass another one and see what happens. Never mind. Never mind. Oh, now, for never mind. For government, whether national or local, implement specific actions, strategic actions through a plan, they need epidemiological surveillance data. And surveillance data is part of the information, of the strategic information a country needs to start documenting what needs to be done in a very compelling, important manner. The second element, that looks better. The second element is the data from labs. Thank you. So here we have in this transparency that the important elements that national AIDS program, COVID programs required are the containment strategies and the mitigation strategies. As I said before, one is to minimize the risk of transmission, and the second one to slow the disease if the disease has already occurred. So if the disease is within the community, we do our best to slow it from continue spreading. The following one, please. Now, as I was saying, the countries count on different sources to harness their plans. One of them is the epidemiological surveillance data. Where is the problem? What's its extent? Is the next transparency available, or it's not moving? It's a stock, I think. Okay, it's fine. It's fine. It's fine. So the governments and the decision makers need to know. That's fine. That's fine. The previous one need to know through epidemiological surveillance what's happening in terms of the extent of the problem, where it is. They need to know through the labs if we are dealing with some type of variants, if we have some changes, some mutations in the proteins of the envelope. We need to make an assessment of the severity of the problem, and we need to respond with clinical management, which is adequate. For example, they can decide that the hospitals need a certain amount of respirators, of equipment, of gear for healthcare providers. That's part of the response. But the following level in which we deal with information is what the community needs to know. The community needs to know that the threat is real, that it has a certain severity, that is spreading, that is not something that we can take lightly. And for that purpose, we need to provide them with information. But for that information, following one, please. The community is a key actor in the implementation of prevention measures. And for that, they need to understand and assimilate what's the role. So they need to get persuasive information. They need to learn that something needs to do. to be done. The following one, please. But for the community, for the community to start incorporating the messages provided through information and get engaged in a response, they need to judge the sources of this critical information truthful, reliable, dependable. They need to have trust. And this is a serious problem because we see all the time, and I'm sure you see that in your countries all the time, that people don't trust the sources of information. I live in the United States, and in this moment, we are living a serious problem with a lack of trust on health authorities, on the health sector, and on policymakers. You probably know who Dr. Anthony Fauci is. I know Dr. Fauci for years and years and years. He has been involved in the response against HIV, against Ebola, against many other health problems. But there is a wing, a political wing in this country that satanizes Dr. Fauci and generate mistrust against him. So anything that Dr. Fauci says is not believed, and people accuse him of doing things which are absolutely despicable. Following one, please. So the lack of trust is the result of several psychological and sociological phenomena. One of them is because people make up assumptions. And I was reading recently something that hit me really hard, that many times these assumptions people make, that in English are called gut feeling, like something I feel with my entrails, are processed in the paleocortex, in the reptilian brain. So they don't go to the frontal cortex. They are irrational, and therefore it's very difficult for people to deal with them in a rational manner because they are deeply rooted. Same with beliefs. I believe so. Don't ask me why. I don't like his face. He's very short. He's a fat man. He's ugly. How can I trust a man who is short and ugly and old? Which are the things they tell about this famous virologist or some other famous people. It could be also to a certain degree rational, not necessarily a gut feeling. It could have been a bad experience. For example, many people were told that the bird flu was coming 5 years ago or 10 years ago and never arrived. So people say, we were told that before. No, I don't believe that. So the trust may be broken against government, against the parties. Here in the United States, everything the Democratic Party says is wrong. So we go, if I'm a Republican, against vaccines, against masks. The Republicans organize big events, happenings, burning masks. It can be against organizations. It can be agencies that, like the World Health Organization. against mass communication networks like Fox, television against CNN. CNN is lying, Fox is hiding, and of course against the authorities. So it's, as I said before, a blend of emotions, but very, very primitive emotions, bad experiences, and sociological events. Next, please. The consequence of this mistrust is that people start having an enormous amount of misbelief, of doubt, of skepticism, and even cynicism. The misbelief is an example of misbelief is it true? I confess to you, when I first about AIDS, I said that's an invention of the Reagan administration, because the gay movement was very strong, the sex education movement was very strong, the women's right movement was very strong. So maybe they were inventing this story of the AIDS epidemic to push back everything. I felt that. So I was like, is it true? Or one can have a certain degree of um, doubt. Maybe this is an exaggeration, is serious, but not that serious. Or frank skepticism. I don't believe it. I don't believe it. That's skepticism. Don't. That's not true. It doesn't exist. Or cynicism. It looks as if we are being manipulated. They want us to be controlled. And the people who are like in a situation of, again, skepticism, like, okay, I don't say no, but I want to see more evidence. And you know what? I know people here in the United States and in the country of Mexico, in the country of Brazil, that they say, I believe now in COVID-19 because they have had a friend or a relative who has died of COVID. This is when they say, okay, now I see the evidence. Too late. Following one, please. Now, the topic of my presentation is misinformation and disinformation. And these are dysfunctional expressions of information at the systemic level, at the structural level, but mostly at the community level. And in these times in which we have the mass media facilitated through digital media, misinformation and disinformation circulate like this. And I see this happening all the time. I have members of my family who have WhatsApp. We have a WhatsApp group, and they send me messages, my cousins, my siblings, and they say, oh, we have heard this, and that. And I say, that's wrong, that's not true. And they say, no, you are wrong. It doesn't matter. I work for the World Health Organization, that I have excellent contacts, that I connected with the health authorities here in the United States, with the World Health Organization in Geneva. No, I don't know. The famous doctor of Houston, who is mentioned in the WhatsApp or in the Facebook site, is the one who knows. Nobody knows who is that doctor, but he knows better than me. So, what's misinformation? Misinformation is a type of information which is incorrect or presented out of context. that it generates confusion. People get disconcerted. For example, of misinformation is saying that people in their 40s and 50s don't get the virus. This is not true. The virus affects anyone. It seems that at least at the beginning of the epidemic that it had a particular impact on the older population. So this was misinformation. But the misinformation was the most terrible thing because intentionally twisted and mostly provided mostly false and distorted facts, deceiving, misleading, and eliciting dysfunctional responses. There is a study conducted by a university here in the United States that shows that the source of misinformation was one person, and this study was made by Cornell University. The following one, please. This is a very cute illustration. It's a Mexican character from the 1900s. It was designed by a man, of course, without the mask, who was a cartoonist in 1910, whose name was Jose Guadalupe Posada. And the character is very famous all over Mexico. Okay, the World Health Organization started talking at the beginning of the epidemic of a problem that was working in parallel with the epidemic itself. The World Health Organization called it infodemic. The infodemic is the dissemination of incorrect information or the spread of bad or debunked information with varying intents and purposes. Those misleading information facts were, among others, the origin of SARS-CoV-2, the virus that causes COVID-19, the dimensions and extent of the pandemic, the severity of the infection, the comparisons with other infection, the bogus treatments and prevention measures, and of course, the conspiracy theories. Following one. So this sounds like funny. It's like a joke, but here in the United States, especially among people of some party, are very affectionate to something called the uh, uh, conspiracy theories, in which they invent some tales, some fantastic images like Star Wars movies about the virus. So one of them, for example, at the beginning they made me laugh because they are creative, they are fantastic. But putting aside the stupidity and the idiocy, they are dangerous because people believe that especially people who are not very educated, or people who are semi-literate or are gullible. I call them the gullible, illiterate, monolingual, conservative idiots. Some people say, and I have seen that among people in the Congress, say that it was a bioweapon uh, created by governments. They say it was the Chinese, it was the Canadians, it was the Brazilians who made it in a lab and released it to control the population. So the theories were so bad that in a country, the country of Cameroon, people started saying that the COVID-19 was in the polio vaccine, and the World Health Organization couldn't vaccinate little kids against polio because the community was against, believing that the virus was there. Some people say, still, some senators here, the most stupid ones, that it was accidentally released from a lab. Again, Mexico, Brazil, of course, China, Canada. So unbelievable things. People say that it was people of certain religious groups, certain ethnic groups. Some people say that the vaccine can manipulate the DNA. Some people say that the virus was created when the companies that provide telephone services, telephone wave services, upgraded to 5G. So it's ridiculous, but believe it or not, there were people here in the countryside that started destroying towers built by companies like AT&T or other ones because they were supposed to conduct 5G waves. And of course, people who say that it came in a meteor that entered in the atmosphere, carrying the virus from Venus, Jupiter, Saturn, Uranus, who knows? Following one. This individual, according to Cornell University, was the source of more than 20% of the misconstructed messages on COVID-19. People say, for example, that and he started saying that the mortality in the world caused by COVID-19 is very, very low, below 2%, perhaps similar to that one of common flu. Well, when you put together all the countries of the world, or at least all the countries which are members of the World Health Organization, and add all of them together, and then obtain an arithmetical average, you will get a very skewed figure. Of course, you have a country like Mexico, which has a mortality of 8.4%, compared to Brazil that has 6%, or the United States like almost 5%. But if you put a country like Comoros, or another one with less than 1%. Of course, you have a distortion of the figure you will have. This is a skewed figure because you have conflated all the figures. So this is a false assumption. Then many tabloids and extremist TV outlets have continued saying that the vaccine is dangerous, is damaging. Many of the commentators on TV say that children shouldn't go back to school with masks because the masks prevent them from getting oxygen, and this would hamper their learning processes. So this is pathetic. The man there, we call him the former guy, at a given point and during a press conference, he said, well, what if we inject bleach or a disinfectant in the system? That might destroy the virus. No comments. People here in the United States say that in China, people eat bad soup, and this is the reason why the virus started spreading. Trump again said that we have many cases because we have more testing. So the more we test, the more cases we identify, which is a fallacy of distraction. Then he also said that people in Africa were resistant. We know it's not true. It entered later, the epidemic, but it's causing a lot of problems. Many people continue believing that some fomites, like objects, can transmit the virus. Well, only if there is saliva or other secretions from the mouth and nose, but otherwise it doesn't happen. And finally, people who say that we don't have any evidence about the use of masks. Following, please. The previous one. We continue doing certain things there that they have no much basis for doing, like washing our hands like every 5 minutes. I don't know if you have that practice, but there is no evidence that washing your hands every hour or so has any protective effect. What I have noticed, and you probably have noticed too, is that doing that over and over and over and over makes for me more difficult to grab papers and pass pages because I lose the fat of the tip of my fingers. So yeah, one has to wash hands, but in a regular, rational manner, not in a compulsive manner. People say that consuming alcohol helps to combat COVID-19. Not true. The alcohol doesn't kill the pathogen in the system. People say have hot teas to kill it. No, no evidence that works. Have vitamin D. No, vitamin D is toxic in excess. Vitamin D shouldn't be taken in excessive amounts. Vitamin D is mostly, especially among young people, metabolized through exposure to sunlight. Chloroquine and ivermectin, no, they are good for paludism. They are good for parasitic diseases. No for COVID. Absolutely no. Chlorine dioxide, it was the thing that in Mexico became like a fad. Everybody was taking chlorine dioxide, which is a poison. Chlorine dioxide is used to clean septic tanks and doesn't work to uh, kill the pathogens, the microbes in there, and stop a little bit the fermentation. People say stop taking meat, red meat, and eat a lot of cabbage. People say take vitamin C. It doesn't work. Not at all. If one needs vitamin C, have your vitamin C through diet. Doesn't work. And the thing that happens with ingested vitamins is that the urine becomes darker, but no function. Yeah. So if someone asks to you as doctors, should I take vitamin C? Yes, in your fruit, in your food, in your vegetables. Vitamin D, no, you don't need it. Have it in your food and go and take sunlight. Okay, following one, please. Panadol is someone asking. Panadol is an analgesic. Yes, if the person has pains, yeah, it's symptomatic treatment, but just for that, not to cure the problem, is to reduce the symptoms. Okay, the misinformation about the vaccine, and please take all these in quotes. People say that it has not been sufficiently tested and not fully approved. No, I had an argument with my niece's husband, who is a veterinary. He said, listen, sir, this has not been sufficiently tested. I said, listen, this vaccine started being tested 10 years ago, and it was tested for the management of MERS and SARS, and the groundwork was fantastic for building this new adjusted vaccine, but the vaccine worked in the tested conducted for almost one year and a half. Not fully approved. True, it's approved here only for emergency purposes, but more than 50% of the population is already vaccinated. So we haven't had any problem. I have a comment here on this side that was distracting me. I took vitamin C, good. It doesn't make any bad. Zinc, it doesn't make any bad. It doesn't make any good. Zinc, I don't know for what, but the studies have demonstrated that it doesn't do any good. Ivermectin, people are prescribing it like crazy, and there are multiple studies that demonstrated that it doesn't it doesn't work, but it's fine. It doesn't make any bad. Any parasites in the system, if they are still there, are eliminated with ivermectin. But it doesn't do anything to the COVID. So it's partially approved here in the United States, only for emergency use. People say that alters human DNA. It's not true because the nucleic acid is built off, doesn't have the capacity to enter into the human cells. Is an antigen that is recognized by the cells of the immune system. They say that it's produced in aborted human embryos. Partially untrue. It's created in a cell line of one human embryo that was aborted like in the 70s. They are supposed to cause infertility. And this is a claim by two physicians that were asked to provide evidence, and they couldn't provide that evidence. Some say that it can cause Bell's palsy, facial palsy. No evidence whatsoever. And there are even one of those internet savvy individuals who say that it may cause antibody dependent enhancement, ADE, after vaccination, but it's people who read something about this very obscure situation, and they couldn't provide any clear evidence. Following one. And the most beautiful one I heard was the woman who went to the Congress and said that she had evidence that the vaccine could magnetization of the system. So she started placing spoons and coins on her body, saying, you see, what she didn't know is that coins and spoons do not contain iron, which is the element to which magnets get attracted, or vice versa. So it was ridiculous. And she was talking, and all of a sudden, all the spoons and the coins started falling, and the representatives and senators stood up and left. They said, she's crazy. And there are people who say that risk of prion disease, there is risk of cytotoxicity. There is a risk, and this is true, of fake vaccines. We have had some few cases that occurred in states where the access to vaccines were limited, and some individuals started injecting distilled water and giving to very gullible people these injections. People say that not all the vaccines are the same. Some people say, I want Pfizer and Moderna, or Moderna, but I don't want Johnson & Johnson. I don't want AstraZeneca. I don't want the Chinese ones. I don't want the other one. They are not good. They are low quality. I want the good ones. I have Johnson & Johnson, and I'm very happy with that. I have a very good level of antibodies, and no problem whatsoever. If we need a booster sometime soon, ready for it. my parents had the Pfizer, and here at home they had the Moderna. None of them is better than the other. Even the Sinovac or the Sputnik are better to nothing. So no big issue with any of them, but people are creating a lot of trouble. Another thing is the vaccine passport as a form of control. People are complaining that these little cards we receive as evidence that we have been vaccinated should be presented to demonstrate that we have the vaccine applied and that we don't represent any risk of transmission to other people. I'm traveling in 1 week and a half, and the airline requests that we show the uh, uh, proof that we have been vaccinated in addition to the mask. And no problem, no problem. Okay, see, following one, please. As I said before, the main source of all this information is the digital media. Uh, uh, Radio, TV, etc., play a strong role, but the main source is the community-based media, the digital media. Following one, please. Before I forget, no, perhaps I can mention it in here. The impact of misinformation and disinformation is that sometimes for the health authorities, the health sector is really complicated to establish appropriate policies and measures. What do we do now? People are never happy. And what people don't understand is if you take a plane, for example, because people complain, they say, "Well, what's the guideline we should follow now?" Fauci say one day, "Go or follow this recommendation." The day after, no, don't. Let us change. No, let us change. And what people don't get is that when we are riding a pandemic, it's like riding an airplane. The pilot can tell you we are doing well. This is smooth. We don't have any storms in front of us. But all of a sudden, it said, "Fasten your seat belts now, because we have a turbulence in front of us." Now, we pass the turbulence. You can relax. You can go to the bathroom. You can walk in the aisles. We have again a turbulence. Fasten your seat belts. And people don't have that discipline. I don't know why. Maybe they are not used to this type of experiences. They have never been exposed to this type of supervision, but certainly for the authorities, it's difficult to establish adequate and sustain policies and measures, and to ensure that there is a good adherence to key measures like masks, to ensure that there is an adequate level of vaccination. People here don't want to get vaccinated because they say it's their right not to be vaccinated. It's my right. It's my body. It's my right. But when one woman talks about her reproductive rights, they say, no, you have none. So it's this contradiction. We continue dealing with the use of bogus treatments. The people continue boycotting some important approaches, and as a result of that, the community of transmission of the virus is back to where we were in May of 2020. I don't know if you are aware of that, but the transmission in some states, Florida, Mississippi, Arkansas, Oklahoma, Missouri, is going up, 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 because the governors of those states said, no, forget about that. You be free, feel free. You don't have to wear mask, and there shouldn't be any mandate. We are not a persecutory state. And now the case go out. So they are having inappropriate policies and measures. Following one, please. Okay, let us finish here with three transparencies with suggested avenues for action. The first of them is trying to identify the beliefs, ideas, fake or distorted information, and get the facts to debunk them. So what do people think? What do people believe? How are the data distorted? And get the facts. Get the facts, but do not confront the people with your fact and against their beliefs. No. What we need to do is to phrase and frame those data for debunking the information in an easy to understand, compelling, and persuasive manner. This is what we did in the past with HIV. When we talked about HIV, for example, we got the information about people who have been infected. So that's the compelling and persuasive manner. So we could get information about people who got infected and what that people who got infected would have done different to prevent what the person went through, and ask them to give their testimony to persuade others. Identify community leaders and partners willing to share the facts on a face-to-face manner in their social media applications. And instead of going against the grain, make of the leaders your partners in this endeavor. Invite them and train them. I was seeing here on the chat that someone was asking me, how do we go about this? Well, we need to conduct workshops with those community leaders to engage them in this community response, but not only how to communicate, but also what to communicate. Following one, please. We need also to count on the educators in the community, the religious leaders, and some healthcare providers. And those healthcare providers are not always the physicians. The healthcare provider can be that nurse, that special one who has very, very good contact with the community. The person people trust could be the midwife. So let us engage the midwife or the dentist, for example, and invite them to be part of this educational and um, communication process. Organize virtual activities to answer questions, pretty much like this one, but with members of the community. It's so easy now to organize Zoom sessions. So tell the community leaders to organize something like this and be the resource of the community leader to answer questions and provide with background information to answer the questions that may arise. Following one. And it's very, very important that you as young community professional, young health professionals, send letters to newspapers clarifying confusing or inadequate information. Ask TV and radio stations for a time to provide accurate information to the public and educate with example. This means show that you are vaccinated, show that off, wear a mask all the time when you are dealing with people, and be someone people can and wish to be like. Last one. So we need many things to deal with COVID-19. We need masks, we need vaccines, we need respirators, we need drugs, we need gear. But for all that to work, we need information. So many thanks for your attention. And I think we can, if we have some time, we can look at the questions we have here in the chat room.
Thank you very much, Doctor, for the very insightful presentation. And I believe that this topic is relevant and relatable to many of our participants here, since it's about the currently real-time issue that is COVID-19. So yeah, I would like to start the Q&A presentation. So Manahil, can you help? And I know that we have some questions from the chat box as well. But firstly, before that, we would like to invite if anyone from the participants, maybe one or two people would like to directly ask questions. If you are interested in asking questions live, you can please raise your hand and we will unmute you. It's in the reactions. So if you're interested, you can raise hand. So while we're waiting for someone to directly raise hand in the reactions, I think we can read the questions. So, Manahil, do you mind sharing the screen for the questions?
Yeah, I think we can move on to the questions we already have.
Yeah, so these questions we compiled are from the Google form, from the chat box in both YouTube and Zoom. So perhaps we can move to the first question. It's from Dan Piaggio from Indonesia.
Okay, so It has been almost 2 years since COVID-19 pandemic. People nowadays seem to have understood that this virus has taken millions of lives. Nevertheless, they still believe this whole mess is being planned. And my question is that how do we educate them? Because we still are not sure about the actual truth behind the pandemic occurrence. So,
Okay, underneath this question, I read a very, very beautiful reflection in which the person who wrote it says, we don't educate people, we learn with them. We don't teach anyone, we learn with the persons engaged in an educational process. The question is, how do we learn with them? I would reframe it, if we ourselves are not really certain of the actual truth. Well, first of all, we need to learn about the actual truth. If we don't learn about the actual truth, how are we going to learn along with a third person? Am I making sense? There is no mystery behind the pandemic. We know a lot of facts about the epidemic, so there is no actual truth. There are some gaps of information about the origin of the virus that will be solved soon. But regardless of that, we should learn about it so we can learn along with other person.
okay, thank you, sir. So moving to our second question from Abdul Qayyum. What about the issues concerning the vaccine not being that effective since some of my friends still got infected?
There is a condition that is recently being studied in which people who got the vaccine got the infection because the vaccine doesn't prevent the individual who has been vaccinated from being infected. It prevents the person from getting a bad infection that sends him or her to the hospital or die. So this is something important to know. Now, how soon after the friend being vaccinated developed the infection? This is something that one needs to know. Maybe the person was already carrying the infection and was vaccinated and developed it despite the infection. So it could be both. The important thing is that one can be vaccinated and still get the infection, but the severity of the infection is much, much, much lower than if the person is not infected.
Can you go to the next one? I will take over from her. So, is there any specific strategies that we need to consider in combating COVID-19 hoaxes in low resource countries? It's from Hayria from Indonesia.
I couldn't hear, I'm sorry.
So is there any spatial strategies that needs to be considered for combating hoax news in low-income countries like Indonesia?
Most definitely, yes. These strategies are the ones I mentioned at the beginning. The strategies are containment and mitigation. Mitigation is, as I said before, once the epidemic is installed in a country and we start seeing the disease in the hospitals, in the community, we extreme the measures to prevent further dissemination. It's different from containment. Containment is when we are at the beginning and we don't see a lot of the cases occurring in the community and many people going to the hospitals. But when the hospitals are starting to be packed with people infected, then we start implementing those measures. What are those measures? The measures are social distancing, first and foremost, the use of masks, the vaccination if vaccines are available, and the avoidance of agglomerations in closed places like malls, like um, um, uh, places for places of worship, which has been a very contentious issue here in the United States, theaters, etc. Is important for people to be apart. If there is a family gathering, when we are in phase of um, uh, mitigation, we try not to have everybody in the house of the grandmother, the 15 relatives celebrating a birthday, everybody without a mask. That's a no, no, no. The mitigation measure in that case would be, let us go and visit the grandmother, but 2, 3 relatives wearing the mask, and we sit at the table and we keep some distance, so we don't put any uh, 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 we don't create a risk situation in the country.
Thank you very much, Doctor. I think since it's nearing the end of the session, so I'm just going to select one more question this time from the chat box. So it's from Pooja Gaigawale. So how one verify information forwarded in the media? Am I audible, Doctor?
No.
Okay, I'm so sorry. So since it's nearing the end of the session, I'm choosing one last question. It's from Pooja. She's asking, how can we know and identify that some information from the social media or news outlets are credible or not?
Exactly what we need, the tool to filter what's credible or not, is educating ourselves. Is what I said before when our colleague said, how do we know what's credible? What do we make our or how do we define our posture of credible? Educating ourselves, and we educate ourselves going to credible sources of information. The credible sources are basically the World Health Organization, the Centers for the Prevention and Disease Control of the United States, and the big universities. They have sites that are devoted to the pandemic. In addition to that, all the universities, absolutely all the universities in your countries, most certainly must have credible, dependable, accurate information in their websites. So go and check it, and then get the facts. And when you get the facts, you know how to filter the information which is of good quality from the bad quality. The World Health Organization, as I said, has a page, and take note of this. It's called infodemics. Infodemics, like information. Infodemics, like the epidemic of information. And they make some suggestions on how to filter information.
Thank you very much, Doctor. I'm sorry, I know I say that would be the last question, but we've got this very enthusiastic questioner, so I will unmute Zainab. Do you mind asking live? Okay, I think.
Thank you for allowing me to ask my question.
Okay, Zainab, you can ask. The floor is yours.
So my question is about the COVID vaccine.
Yes.
And we were told that it doesn't change the way your cells replicate DNA. Is that true?
You have been told what?
We have been told that the mRNA and RNA DNA vaccines.
Yes.
We were told that even though it gives your cells the information needed to, create those antibodies to help fight the spike proteins and all, we were told it doesn't really change your cell's DNA.
Absolutely no. Absolutely no. It's just an antigen that contains a little fraction of the nucleic acid of the virus, and the immune system of the person who has been injected with that little portion of antigen reacts against the antigen and develops antibodies and other substances to combat that specific antigen. So when the virus enters, if it enters, the person immediately, or rather, the immune system of the person immediately reacts against it and combats it.
Okay.
But it doesn't enter to the cells. It's attacked immediately after it enters the organism. It's like any other vaccine. We have been injected with many other vaccines. When I was a child, I was injected first with dead polio virus, and then in 1960 I was given a live attenuated polio virus. And I swear to you, I don't have the DNA of polio virus in my system. I have the antibodies against the polio virus. And all the vaccines function like that.
Thank you, Doctor. And Zainab, we hope that it answered your question. Since we're coming to the end of our session today, I would like to once again ask the participants to open their cameras, and so we can have a photo session with a very insightful speaker today, Dr. Mazin. And while I'm waiting for all the participants to open their cameras, I would also like to thank Dr. Opara. Thank you very much, Doctor, for staying until the end of the presentation, until the end of the session. We look forward to collaborating with both Dr. Mazin and Dr. Opara again in the future, because as you can see in the chat box, all participants are telling that it's very insightful and that it helps them a lot. So thank you once again for kindly giving your time. So now I'm going to start taking the pictures. Okay, so it's 1 to 3. Okay, kindly bear with me for a second. And then once again. And yeah, so for participants, actually, this is the end of the session. So if you can please open your cameras, because we're closing the session after this one. Okay. Thank you.
Thank you.
1, 2, 3. Yeah. Thank you very much, Doctor. That was very insightful, and we are very honored to host you. And so thank you, participants. This is the end of the session, and I believe we've put the link in the chat box. Kindly copy it, and you can also chat us if there's any problem accessing it, because we won't be sharing the link in the group, because we fear that many in the group didn't join this meeting today. We have some from session 2 as well in the group chat. So kindly copy the link there. I will keep this room open for 5 more minutes in case you have any problems accessing the link. So yeah, I'm Adriana Piola Miranda from Indonesia on behalf of SAC and also the organizing committee of the SAC Global Health Program. I am hereby closing the first session of the Global Health Program, and we can't wait to meet you all again in our next sessions with very insightful speakers, also just like the session we have today. In case you have not registered to the session, you can open our registration link. It's the same link that you use for our session 1. So you can just refill the form and choose session 2 and session 3. Thank you, everyone.
Hola, jefes.
Thank you, everyone.